Hello, and welcome to the NCCN Policy Summit webinar, Health Literacy in the Cancer Care Digital Age. My name is Crystal Denlinger, and I serve as the Chief Executive Officer of the National Comprehensive Cancer Network. On behalf of NCCN, I would like to thank you, our virtual audience, for joining and participating in today's summit. The topics are far too complex to fully address in just one webinar, and we hope that the oncology community and you as our audience will continue these conversations by carrying them with you online and in person to those who are unable to join today. The focus of today's summit is policy and practice strategies to address health literacy concerns for people with cancer in the modern digital age. According to the National Library of Medicine, nearly 9 in 10 Americans struggle with health literacy. While difficulties understanding medical terminology can impact treatment adherence and outcomes for patients dealing with any medical condition, the risks and complexities inherent to a cancer diagnosis serves to heighten disparities in health literacy levels and their corresponding patient outcomes. Moreover, our current health systems are not designed to adequately monitor and support individuals with lower levels of health literacy, especially in an age where social media and increasingly sophisticated artificial intelligence systems facilitate exposure to medical information of questionable veracity. Today's topics will explore the impact of health literacy on shared decision-making, the need for culturally tailored, plain language communication, the impacts of social media and integration of artificial intelligence on health literacy, and strategies to promote health literate organizations. Discussions may also include how payers, care teams, and other healthcare stakeholders are addressing health literacy and how these initiatives may affect patient access to guideline-adherent care, along with policies to support and educate patients. NCCN is very grateful for the many supporters of today's program. We'd like to thank our sponsors for their generous support because without it, this event would not be possible. Today's agenda is shown here and is a combination of a keynote address, a panel discussion, and best practices presentations. We welcome all of today's speakers, and I want to thank them for their time and sharing their expertise with us today. We thank our expert speakers for generously sharing their time and insights today. The perspectives and opinions shared today are those of the presenters. Our moderator for today's panel is Dr. Clifford Goodman. For those who are familiar with NCCN, you are also familiar with Dr. Goodman, who is an expert consultant in health policy and technology with over 30 years of experience working with government, industry, and nonprofit organizations across the United States and abroad, with areas of expertise in health technology assessment, comparative effectiveness research, clinical practice guidelines, and health economics. We're thrilled to have him join us today to moderate today's discussions. I would like to introduce today's keynote speaker, Dr. Robin Vanderpool. Robin C. Vanderpool, DrPH, is the Chief of Health Communication and Informatics Research Branch at the National Cancer Institute, where she leads a team dedicated to the development of research initiatives in areas such as cancer communication, surveillance, patient-centered communication, digital health, and online information. Dr. Vanderpool also collaborates with the Cancer Information Service, an essential part of NCI's information dissemination efforts, as well as the NCI Office of Cancer Centers on catchment area, rural cancer control, and community outreach initiatives. Prior to joining the NCI, Dr. Vanderpool was a professor in the College of Public Health at the University of Kentucky and Associate Director for Community Outreach and Engagement at the UK Markey Cancer Centre. Welcome, Dr. Vanderpool, and thank you for joining us.
Thank you so much, Crystal. It's always an honor to be here on behalf of the National Cancer Institute. I want to thank you all for the opportunity to present this afternoon. And again, it's always a pleasure to be with NCCN and its audience and its constituents and really think about and talk about these important patient-facing issues. And I really appreciate the timeliness of this webinar series. My presentation is Health Literacy in the Cancer Care Digital Age and Patient-Centered Communication. And, really what I want to highlight for everyone and remind us is, again, why we're here, just to revisit the importance and prevalence of cancer in the United States, and to think about how important the timely and quality cancer information is in the journey of a cancer patient and caregivers and providers, and even the general public when they're seeking cancer information. But as Crystal in her introduction noted, we're really in a day and age where everything is changing all the time. So I want to talk a little bit about health recommendation messaging and how the public views that. I want to talk about just how overloaded we are by all the different technologies that we have available to us. Really hone in on digital health literacy as something we need to be considering as a specific focus of health literacy overall. I want to hone in on the patient-provider relationship and how important and I would argue definitive that is in this crowded information ecosystem that we have. And before I begin, I do want to indicate that I have no conflicts of interest to disclose. I also want to state that any opinions expressed by me today are my own, and that this presentation should not be interpreted as representing the Department of Health and Human Services, NIH, or NCI. And again, timely to what we're talking about today, I do want to disclose that I did use AI to generate some of the graphics that I used throughout the presentation. Crystal hinted at this at the top of her comments, that certainly there's no way we could cover all the ground related to health literacy and this cancer care digital age that we find ourselves in. That really, I think our discussions are the tip of the iceberg. And I hope that my presentation, along with the other panelists and their remarks, provides us with a lot of food for thought and a lot of ideas for action. As I alluded to earlier, I do want to set the stage and remind us of why we are all here. We know that cancer does remain the second leading cause of death in the United States, that approximately 40% of men and women will be diagnosed with cancer in their lifetime. And according to estimates from the American Cancer Society, there will be over 2.1 million new cancer cases and over 620,000 deaths in 2026. So again, just setting the stage for the magnitude and importance of the topic at hand. And then, layered in with those other statistics, given the advances in cancer screening and early detection and treatment, as of May 2025, there are 18.6 million cancer survivors in the US, which is roughly 5% of the population. And the number of cancer survivors is actually projected to grow to 22.4 million by 2035. And as part of the cancer care continuum, and that's thinking about prevention all the way through, again, screening, treatment, survivorship, end of life, we know that it is vital that patients and the public and caregivers and providers have access to and then apply timely and quality cancer information, which in turn can have a very positive effect on cancer outcomes. And these outcomes range from increased knowledge and understanding of the disease itself to actual behavior change, such as tobacco cessation or medication adherence, to higher satisfaction and engagement with one's healthcare, improved patient-provider communication, which we'll talk about a little bit later, engagement in clinical research, and reductions in cancer disparities. Collectively, across public health and clinical care, we've long recognized that health literacy influences an individual's ability to find, understand, and apply cancer information and the related services to inform their healthcare decisions and the actions for themselves and others. And that we need health literate organizations to help enable and empower this process among individuals. But now more than ever, regardless of our health literacy skills, or even maybe compounding with our health literacy skills, we find ourselves in a very noisy and a very complex health communication ecosystem where health information changes maybe by the minute, if not by the day, where if you kind of take this cartoon tongue in cheek, that you spin the wheel and you can have a risk factor or an exposure or a medication or a supplement that can cause or even cure a condition in varying populations. And then that can even change again with another spin of the wheel. And the public certainly recognizes these constant changes and the uncertainty in health messaging. As reported using our most recent Health Information National Trends Survey data from the National Cancer Institute, almost 70% of US adults report that health recommendations from experts commonly change over time. And almost 60% of US adults report that health recommendations from experts commonly conflict or contradict one another. And findings from a Pew report published last month found that almost 30% of US adults report often or extremely often seeing or hearing health information that conflicts with other health information they've gotten. And another 15% say it is very or extremely difficult for them to know which information to trust when they see this conflicting health information. And as again at the top of our introduction from Crystal, this is extremely concerning given what we know about cancer and how vital it is to have trustworthy and consistent messaging. And to be honest, why wouldn't we expect this uncertainty and this confusion to be the case when we are, as a society, we are in a digital health information ecosystem overload. We have health information coming at us from every direction. For example, did you all know that there are over 350,000 health-related apps in the Apple App Store? And that's not even including Google Play and any of the other cell phone platforms as well. How many of us right now are wearing some type of wearable device that's generating data about our heart rate, about our activity, our steps, our sleep habits? And we're inundated with often questionable health information via social media. We have numerous media outlets through newspapers, the TV, and even podcasts have joined the club. We've had a significant growth in the use of patient portals and electronic health records and the amount of information about ourselves from our medical records that are imported into that. And of course, the new face on the scene, AI tools and chatbots. It's evident that we must recognize the elephant in the room, and that is artificial intelligence and the force that it's become in our health information ecosystem as its use continues to grow among both patients and providers. And so now as a community, we have to focus even more so on a specific type of health literacy, and that is e-health or digital health literacy, which is an individual's ability to seek out and find, evaluate, integrate, and apply what is gained in these electronic environments that we're talking about in order to solve a health problem. And this is a skill that requires people to be able to work with technology, right? How are we navigating, the webinars that we're on today? How are we navigating telehealth? How are we navigating broadband and digital access? How are we navigating all of those sources that I pointed out earlier? And then how do we critically think about the issues of media and science? How do we weed through and find the facts? How do we navigate, again, all of those information sources that we talked about on the prior slide? and then ultimately make a decision about our health. And as part of this emphasis on digital health literacy, we need healthcare organizations and healthcare providers more than ever to be adept in enabling and in empowering individuals to navigate this cancer care in the digital age. Because there is a lot at stake, especially within the cancer context. A lot of things can go wrong. And if you'll recall, right at the start of my presentation, I shared the positive benefits of timely and quality cancer information. But here on this slide, I've outlined the potential negative outcomes of this complicated and chaotic health communication environment. And again, using the cancer case for this. And across the continuum of cancer care, we can see negative effects such as negative effects on decision making. For example, whether someone vaccinates their child against HPV for cancer prevention, someone delays cancer screening because of some perhaps misinformation that they've heard, or the use of unproven therapies that could truly affect their cancer treatment outcomes. We can also see consequential changes to the patient-provider relationship, such as decreased trust and perceptions that perhaps an AI-generated response is right and the doctor is wrong, and the relationship becomes perhaps fractured or contentious. This cancer information environment may also result in patients being anxious, confused, or even apathetic of just, there's too much information and I just can't deal with it all, so I'm not going to do anything. We also have direct financial implications when patients may purchase, again, these unproven therapies or be swindled through all these social media platforms. We also know that limited health literacy, and I would argue even digital health literacy, may play out as patients navigate the financial burdens of cancer treatment. And another topic, perhaps for another day, is also health insurance literacy. Something that we're all passionate about is, even though often technology can democratize information, making it available to everyone, there are still issues around the digital divide, and that can indeed exacerbate cancer disparities. And especially when we have people who don't have reliable access to the internet and broadband, we have, again, the limited health literacy skills. We don't have access to high quality language concordant health information. And of course, the broader social determinants of health and how they impact our day-to-day interactions and our day-to-day and our need for healthcare. So in my remaining time, I want to recognize that although this all does seem quite distressing and quite overwhelming, that we can't lose sight of the forest for the trees, that we truly need to focus on the basics of communicating to individuals at the right time, the right place, the right channel, the right source, with the right information for the right literacy levels. And indeed, I'm looking forward to hearing about the best practices and innovative strategies from my fellow speakers today. And as eloquently stated by this Lancet Oncology article from December, our actions must be done with patient-centered communication, empathy, cultural humility, ethical reflection, and psychological care, as this is foundational to the practice of cancer care. And at the heart of this focus on patient-centered communication is that valued and trusted and significant relationship between patients and their providers. The National Cancer Institute has long prioritized the importance of patient-provider communication and the 6 core functions highlighted here on this slide. And, it's important to note that health literacy has a role to play in each and every one of these 6 core functions. If you start with the first one, we need to build trust and rapport using clear and respectful communication that invites a bi-directional questioning and conversation between patients and providers. Number 2, we need to share information in plain language to ensure mutual understanding. Number 3, we need to respond to emotions and emotional cues and respond with empathy and clear communication. Number 4, we need to manage uncertainty by explaining it, what is known and what is not known in understandable terms. We need to make decisions in a collaborative way with patients that uses clear information to support informed and value-based decisions. And we need to empower patients with clear, actionable instructions to manage their care and their health. And, to be honest, what we need to come to terms with in today's environment is that it's not an either or circumstance, that both things can be true, that patients are indeed getting health information from their providers in that trusted way, but they're also getting health information from many, many other sources, including peers, websites, the news, government, social media, and AI chatbots. And so, how can we advocate for that patient-provider relationship to be the definitive, authoritative source of health information and conversation above and beyond all of these sources? And again, using a recent Pew report, I am heartened to see that 51% of adults say they often or extremely often get their health information from healthcare providers more than any other source, which, if you look at the numbers, is either double or more compared to the other sources. But let's be realistic. We are going to need to monitor these estimates as we continue to see increased usage of AI tools for health information seeking. A different poll that came out from Kaiser recently tells us that sources such as AI tools and chatbots are really being used for quick and convenient and immediate health information, helping people to decide whether they should see a provider, helping them maybe review medical results before they're able to discuss it with a doctor. And in roughly 20% of cases, AI is being used as a major reason for health information due to lack of access to providers, and lack of access to care, and due to cost reasons. So these are things we also want to monitor, because again, the flip side of exacerbating disparities. Next slide. And you can actually see where some of these disparities bear out in that younger, those folks aged 18 to 29, as well as individuals who have household incomes less than 40,000, they are more likely to have higher rates of using AI when they can't afford to see a provider and if they don't have a regular source of healthcare. And to my earlier comment about providers being that definitive or final source of health information, the same Kaiser report reveals that 42% of individuals using AI for health, what they call physical health information, didn't follow up with a healthcare provider, and 58% didn't follow up with a provider when they had been using AI for mental health information. So again, this really reiterates that need to reconnect patients and providers. And I'll argue that it's a two-way street, that we need to encourage patients to follow up with their provider and discuss what they've learned in this online environment. And we need to encourage providers to proactively ask their patients about their use of digital health sources for cancer information. Because although health websites and AI chatbots actually score more points for being convenient, as you can see here again from this Pew report, healthcare providers rank by far the highest for ease of understanding, personalization and centeredness, and accuracy of information. And another data point that's specifically related to cancer, our HINTS-7 data indicates that 71% of US adults trust cancer information from a doctor a lot. And so this gives us, again, I'm heartened by this notion of this remaining in high trust in the healthcare provider relationship. And as we can see the importance of provider communication, highlighted here, I want to showcase the importance of provider communication and recommendation in several digital use cases. Again, using our HINTS data, on the left, 57% of US adults have been offered telehealth by their provider, which in turn being offered and recommended results in 80% of them uptaking telehealth for a form of care. And the top reason for choosing telehealth is that their provider recommended it or required it, with 73% reporting that top recommendation. And then on the right, similarly, we see that 61% of US adults have been offered EMR access by their provider, resulting in almost 70% of them moving forward and accessing their EMR at that recommendation. Related to clinical trials, among those individuals invited to participate in a clinical trial by their provider, almost 50% of them did so. And when we asked our HINTS respondents to imagine a need for clinical trial information, healthcare providers were the number one choice at 60%. And that was followed by the internet further down at 20%. And that the most trusted source of information about clinical trials, which are so important in the cancer space, it was reported, physicians again reported as 70% as the most trusted source. And following this same theme of empowering patients to discuss online health information that they've encountered out in the wild, if you will, with their providers, or even vice versa, having the providers proactively ask patients about their use of online health information, we're seeing an increasing trend among the public, with over 1/3 of adults reporting that they have discussed online health information with providers. Which again, I think, not that the two surveys are linked together, but it does support or align with this notion from that prior Kaiser survey that I mentioned, that I think what's happening is that, cancer patients, caregivers, the general public, they're using this online ecosystem to first look up things or to ask questions or to do their research before an appointment with a provider, or to interpret findings before they've gotten a chance to have that one-on-one conversation, but then bringing it to their provider for that bi-directional engagement. And that's something I think ideally, we actually have HINTS 8 in the field right now asking these questions again, and I anticipate that number will continue to go up. And then when we examine the same HINTS data further, we see that 86% of those who did discuss online health information with their providers agreed or strongly agreed that the provider was open and respectful in that conversation. And another 27% believe that the discussion of online health information improved their interaction with their provider. And as you can see here, almost 2/3 indicated that there was no impact on their relationship and the interaction with the provider, which I actually think is good. I think it means that it's maintaining the patient-provider relationship. Where I would argue we still have work to do, though, is that obviously 14% of these interactions were not, the provider was not open and respectful, and another 9% where the interaction actually got worse. And so I think we have to think about the provider training that comes with this as well. In fact, with this same HINTS data, doing an even deeper dive, we might even see some bias among providers. We can see here that individuals who have reported high internet search skills, they're more likely to report that a provider was open to talking with them about that online health information. And this may speak to the fact that providers may have biased perceptions about patients' digital health literacy skills and may not be as open to discussing online health information with them, particularly if they judge that information that was shared by the patient to be of low quality. We do see in another data point a strong association of having past experiences of high patient-centeredness care and perceiving providers as being open to talk about online health information. And again, we perceive that to be that this openness, again, to talk about online health information is truly part of patient-centered care in this modern information environment. And why does all of this matter? In a scoping review of patient-clinician communication about online health information that a team is doing here at NCI, they found that when providers are open and encouraging, patients feel empowered, they're more satisfied with their experience, they ask better questions, and they're more knowledgeable. Whereas when providers are dismissive or discouraging, patients feel disempowered. They may have higher levels of mistrust of their provider. They may seek alternative care. And again, what we've seen in some other data is that they're just using that information from online to manage care on their own and not seeking out that provider relationship. And I want to close with an additional suggestion that we can also use trusted interpersonal sources of cancer information beyond clinicians. This really speaks to that value of organizations being a key partner in addressing digital health literacy. And I do want to take an opportunity to promote the National Cancer Institute's Cancer Information Service. Believe it or not, it's still a service that is answered by human beings. It's been in operation since 1975. It's free, it's confidential, and it's a resource for evidence-based cancer information and has been serving millions of individuals with an interest in cancer, directly with bi-directional conversation and engagement. And the next slide just shows that it has numerous access points. We still have a 1-800 number. We also have instant messaging through cancer.gov, email, social media, and other public inquiries that all, again, is a human being interacting one-on-one in that interpersonal way to help address questions and concerns about cancer. And I just wanted to highlight one area where the CIS really excels in this is training tobacco cessation counselors and motivational interviewing techniques that helps people, again, one-on-one develop a quit plan, set a quit date, manage cravings, and deal with those psychosocial triggers and setbacks. And there's also supportive callback counseling that comes with that. Beyond the general public, the CIS also works with the Veterans Administration, the Department of Veterans Affairs to help veterans with tobacco use cessation. And again, tailoring the different sources and content for people. Still a good old-fashioned 1-800 number, but also text messaging, smartphone applications, and web-based tools through smokefree.gov are all available. And then the next slide highlights that the CIS really does play an important role also for cancer clinical trials, both patients, caregivers, and providers, where information specialists make that complex clinical trial information that you might find online. They help them specifically with customized and personal searches of clinicaltrials.gov. They provide a case management service, again, where they'll call back and check for understanding and check that the information they have received, that they're able to understand and use that information. They help them address barriers to pursuing a trial and any other information needs they might have. And so the last slide, I believe my time is coming to an end. I want to reiterate that this is just the tip of the iceberg. There's so much to consider and so much to discuss, and I look forward to the remaining portion of this webinar, and I welcome questions and interactions with my fellow panelists. Thank you very much,
Dr. Vanderpool. Well presented, and among the many points you've made to us is that health literacy is really a continuum. And if you don't get the top of the cascade right in the first place, it's not going to go well thereafter. And so That's a great point. Also, I commend that you brought to our attention the HINTS survey. I don't think a lot of us knew about that. I'm just going to briefly fold a couple questions into one. You did talk about disparities and you talked about personalization. Many of us remember when cancer was one disease, then we remember when it was tens of diseases, then it became hundreds of diseases, and now it's really approaching thousands of diseases, and any one person with cancer, pancreatic, prostate, what have you, it changes even during the course of my experience with a cancer. How can you come back to personalization for just a minute or so? How do you help people pinpoint and truly personalize cancer, given how much we know about how differentiated it is?
Right. I think that's, we talk about precision oncology, right? And I think that's what you're getting at, Cliff, with how personalized and specific treatment options can be now for different cancers. And especially now that we, have all the different novel therapies, immunotherapies, targeted therapies, et cetera. And even now cancer vaccines coming on the stage as well. And I think that goes back to really figuring out the right place, right time, right information, right, what does that patient need, not just at the beginning of their cancer journey, but at each step of that cancer journey. And I think that's where, I used to be an information specialist for the CIS back in the day.
Mhm.
And one of our biggest talking points was always check for understanding. And I think that's what we have to do at each step of the way, because you may, and especially if your treatment changes, or it may be a patient, isn't responsive and may need to switch to a different course or needs to go on to a clinical trial. I think you just have to meet the patients where they are. And I would hope that the collective, whether it's the nursing staff, the providers themselves, the social work team, that's the other part. I think it takes a full team approach to help meet the patients where they are too.
Well, meeting where they are is one area that we're going to get into in just a few minutes with regard to the digital stuff and the AI stuff and using social media to that advantage. Dr. Vanderpool, thank you very much. I think you help personify what's really an extraordinarily transition for the NCI. It's not just funding great biomedical research in cancer and then getting stuff into the peer-reviewed literature. Your job's huge now, with so many frequencies and media and so forth. So good luck. I, for one, am glad you're the person who's sitting at the desk where you're sitting, because I think you're the right person to have it there. But that's a big job you've got. And we really appreciate your taking time with us today. Thank you so
It
much. And
is.
we'll drag you back into this someday.
Sounds good. Thank you.
Thanks,
Thank you
Dr.
again for the
Vanderpool.
opportunity.
Sure enough. Thank you. Okay. Well, that's a great way to move into our panel here, our special panel. And this panel discussion is on, we're calling it From Information to Insight, Reimagining Cancer Literacy Online. And just a few sort of logistical notes here. This session is going to run until 3:10 Eastern Time, 3:10 Eastern Time. So we're approaching a total of 90 minutes. Of that 90 minutes, we're going to try to conserve about 20 or 20 plus minutes for Q&A. I will tell you that we already have some pre-submitted questions, which could probably take up almost all of that, but I'm not discouraging you from putting questions in if you've got them. We'll try to get to as many as we can. In a moment, I'm going to have our panelists introduce themselves. But before I do, I just want to make sure that folks understand the main topics that we really want to cover here in our time. We're going to try to get to all of the following: the health literacy landscape, shared decision making, enhancing patient-provider communication, social media, AI, plenty to say about that, the policy outlook for improving health literacy, and the idea of health literate organizations, which until recently, that's a pretty new term to me. And then we might have a surprising closing question for all that. So this is kind of since we have 6 panelists in limited time, I'll tell you that for our attendees, that this is kind of a brisk conversation, and our panelists are going to kind of hit the high points, the most powerful points with regard to the various areas. I've got a pretty good idea of whom I want to go to first and second for these questions, but all panelists are going to be involved for much of the program here. So with that, I'm going to ask Dr. Chambers, Laura Chambers, to introduce herself. Here's what we're going to do: name, title, affiliation, and in just a sentence or two, your connection to this topic. Dr. Chambers, Laura Chambers.
I'm Laura Chambers. I am a gynecologic oncologist and an assistant professor at The Ohio State University Comprehensive Cancer Center. And my connection for being here today is I have a strong research interest and connection to social media and cancer and how that impacts patients and also the quality of information to be found on social media.
Excellent. Great. Thank you. Dr. Dizon, Darn Dizon.
Yeah, hi, Don Dizon, the chief of the Hematology Oncology service line for Tufts Medicine here in Boston, Mass. This long time social media early adapter. But I think for purposes of this, I'm also founded a group that was generated online called the Collaboration for Outcomes using Social Media in Oncology, which is a national group.
Excellent. Thank you. Dr. Dumenchi.
Hello, I am Levent Dumanji. I am professor of biostatistics at Temple University. My educational background includes psychometrics and related statistical methods. My interest in health literacy comes from an NCA grant that I developed two instruments from 1,300 cancer patients. One is called Cancer Health Literacy 30. So this is an instrument designed to measure cancer health literacy, not health literacy. And Cancer Health Literacy 6, that's designed to identify persons with limited cancer health literacy.
Well, thank you very much. We need a quant guy here, and somebody that does kind of analytics.
I am here.
And instrumentation and instruments here to measure, to assess. Next is Dana Gaiman Spencer.
Hi, Cliff, and hi, everyone. I am Dana Gaiman Spencer, and my what I do is that I lead strategy and innovation for our Center of Population Health here at Genentech. And my interest in this subject is based on my lived experience, having struggled through my own health literacy challenges.
So you got a couple hats on there, Ms. Gaiman Spencer. Thank you very much. Next is Dr. Jackson, Devlin Jackson.
Hi, everyone. My name is Devlin Jackson, and I'm an assistant research professor in the Department of Behavioral and Community Health at the School of Public Health at the University of Maryland. And my research focuses on working with communities across the community engagement continuum to design digital health tools as well as health information content to support their prevention health behaviors. And one of my roles explicitly as it relates to the context of cancer prevention, I am the faculty director of program and implementation in the Office of Community Outreach and Engagement in the Greenbaum Comprehensive Cancer Center, where I lead the Cancer Health Ambassadors program, as well as a PI of some cancer prevention health communication initiatives right now being funded by the state.
Well, thank you. That's a lot of qualifications for this panel. Glad you're here. And then Dhruti Ramchandani.
Hi, everyone. My name is Dhruti Ramchandani. I'm a public health professional as well as a gerontologist. I'm at City of Hope National Medical Center, where I am a program manager in the Division of Patient, Family, and Community Education. And my connection is really that my role is rooted in advancing organizational health literacy. Our team is dedicated to developing and integrating patient and caregiver education initiatives across our national system. We're focused on making education credible, accessible, and meaningful throughout the cancer journey, and really truly on supporting our patient-facing teams with the resources and strategies to best deliver this patient communication throughout the trajectory. So thank you for having me here today.
Thank you for being with us very much. Our first topic, then, we're going to jump into the health literacy landscape. And you heard from our keynote speaker with regard to kind of the stats, some of the discouraging statistics about the lack of health literacy. And what we'd like to find out here from the next few panelists is what are some of the factors that play into that statistic of diminished health literacy? And are you seeing any trends in one direction or another along the way? And I wonder if I could go perhaps in this order. I'm trying to think how we can play this out. Maybe Dr. Jackson first, maybe getting into the different definitions of health literacy, if you could help us out with those. Dr. Demenci, a little bit about the distinctions perhaps between general health literacy and cancer health literacy, and kind of give us a hint to what you've found there. Dana Gammon Spencer, perhaps organizational health literacy and how that might inform the development of communication. A little bit of that, and I'm going to come back to you later, by the way, in organizational health literacy. And then I'm just wondering, Daruti, if you could perhaps get into a little bit about how digital health literacy builds on the foundational health literacy and kind of where the main deficits are. So this is mostly about what does the landscape look like and what are those factors? So Dr. Jackson, could you kick it off?
Sure. I apologize if there's any noise in the background because of where I am in my window. But some factors that have already been noted, but I want to add a little bit of addition to, is thinking about when we think about health literacy and some of the areas where we could do some more work or be more intentional about how we approach these efforts is around thinking about how education plays a role. I think oftentimes we see in reports that it goes straight to, oh, those with less than high school education or less than college education. But we have to remember that it's a paradox, right? Meaning that one who has college education, that was noted earlier, that they also might have some challenges as it relates to health literacy or health information that they are receiving. We see these challenges when trying to decipher between health care and healthcare coverage, trying to decide which thing is the best approach for our treatment and our care, because healthcare coverage can be very complex, right? And so it doesn't, for some people, it doesn't even matter what their education level is. And that's just one area when we think about how education doesn't necessarily deem as a predictor of, oh, you have this certain level of health literacy to be able to navigate these systems when we think about our cancer care and treatment. Another factor that I wanted to note is that we still see this trend of folks reporting about how race and ethnicity play a role. Yes, race and ethnicity, we are seeing differences there as it relates to health literacy. But it is also important to know when we're looking at these trends and we're trying to determine like the best programs and interventions, that we aren't looking at race and ethnicity as this like biological risk factor that, okay, if you identify as, then you are therefore going to have this level of health literacy. But more so looking at it from the lens of, okay, what are some systemic institutional factors that we need to take into consideration for why those health literacy levels are what they are and showing up within these communities of color. So those are some factors that I wanted to highlight and note as we think about education, as we think about race, that are some trends that we constantly see, but a way that we should be thinking about them rather than just the conventional, oh, so if it's this, it must be that, but looking at it more complex.
Point very well taken. It's not just what box you check on the race or ethnicity kind of multiple choicey thing that drives this thing. We've got to look at it much more carefully, much greater discernment, and we're probably not as good at that as we need to be. And I'm so glad you pointed that out. Dr. Demenci, you've been the person who kind of measures all this, and I know that you've done some careful work in kind of what a threshold is or a cutoff point for health literacy without giving us the whole research that you've done, but can you hit some highlights for us?
Sure. First off, I think we need to distinguish health literacy from cancer health literacy. At the time, we were validating the instruments. We use efficacy of making health decision as an outcome. And the reason we use this, because this is the only outcome embedded in the definition of health literacy. So controlling for important covariates, we found that cancer health literacy is a significant predictor of efficacy of medical health decision. That wasn't surprising. What was surprising was that two most widely used health literacy instruments, SOFLA and RAL, are not significant predictor of most important outcome. So
They're
that's
not
why
predictive. You're saying they're not predictive.
they are not.
Aha. Even though we've been using it. Yeah.
We are talking about sample size over 1,300 cancer patients. So we have to be, I mean, I can speak for myself, have to be very careful about distinguishing cancer health literacy from health literacy. The second point I like to make is that I was writing a manuscript about limited cancer health literacy rates. And I found multiple meta-analyses, multiple studies. And when I look at the rates of limited health literacy, it ranges from 0% to 99%. Basically, we know nothing. So, and one reason is that people are using continuous score and come up with an arbitrary cut points to define who has adequate cancer health literacy, who has limited. So for that, we use cancer health literacy test 6. It uses psychometric model-based estimate using
Say the name of it again, please. It's called the what?
Cancer Health Literacy Test 6.
Got it. 6.
So it uses psychometric based modeling, not a cut score, to identify persons with limited cancer health literacy.
So, Dr.
So,
Dumenchi, then you're saying that the 6 test, that is more reliably predictive?
so what it does is that when the instrument identifies a person with limited cancer health literacy, it does it so with 95% accuracy. If you look at the medical test, when you go see a doctor, take the medical test, their accuracy rates range between 80% to 90%. Some are 95%.
95 is pretty good. Yes.
So by using model-based estimate to determine persons with limited cancer health literacy, what happens is that we can make sure that when we use the term limited cancer health literacy, it has the same meaning for people with African Americans, whites, males, everybody. Once we establish this, because I am using the phrase limited cancer health literacy, we first establish that it has the same meaning. And then we can estimate group-specific rates and compare them.
Very helpful. So this is helpful. We've been talking about health literacy and more recently cancer health literacy for many years, but we haven't been so good at measuring it or assessing it, and we need those tools. So thank you for raising that. Dana Gaiman Spencer, you've got an angle on this as well, because I know you're wearing 2 hats, but tell us a little bit about the landscape of cancer health literacy from your perspective.
So first, I just want to acknowledge that I think that the data that Dr. Vanderpool mentioned that everyone is talking about of 9 out of 10 US adults struggle with health information, that's meaningful data. So that means that many of us on this panel also struggle and have had times where we've heard things that we don't fully understand. And so when I think about additional factors that contribute to that, it's the emotional factor. Anyone who's receiving a diagnosis of the big C, so to speak, that changes everything because you're no longer operating in this prefrontal cortex. You are operating off of emotions. And so maybe you don't understand what you would have understood in those circumstances. So I think that's a reality when patients and caregivers are going to the doctor and you're hearing a diagnosis. There is something to be said about the emotional aspect to that. And because the truth is that it is a systemic problem. It's not just an individual problem. And Dr. Vanderpool showed the data from the Health and Human Services release of Healthy People 2030 that basically redefined the definition of health literacy to include organizational health literacy. So it's personal and then it's also organizational. And that definition of organizational says that organizations within the healthcare system have a responsibility to ensure that the things that they put out for patients and caregivers are plain language, culturally relevant, and meet the needs of the patients. And that's exactly what we need to start doing as organizations and what we're trying to do here at Genentech.
Point very well taken. And I just to turn quickly to your earlier one with regard to once you've got that fog of a cancer diagnosis, it's kind of hard to be oncologically health literate because there's so many other things with which you need to cope. So thank you for those points as well. So Daruti, I think you have got a bit to add about the health literacy landscape in oncology. What was that point you wanted to make?
I do. And if you don't mind, I just want to double down on the message that each of the panelists have made about health literacy. We really try to focus on the concept that anyone at any point in time can experience poor health literacy. And it's to all the points that have been made with this life-changing information coming at them all at once, stress and fear, affecting comprehension and memory, really. So back to my point, I'm just so happy to hear all of this coming together. But regarding the digitization of just about all information, we've been navigating this infodemic. And so we have information coming at us from all different directions. And digital health literacy is essentially building on foundational health literacy. In that digital tools will require both health literacy and then the digital skills to navigate this platform. So it assumes that patients can first understand the health information and how it's being presented. And then we're layering on top of that and asking them to navigate portals, telehealth platforms, remote monitoring tools, and now AI chatbots and other things like that. So I think a key message around digital health literacy is just how thoughtful we need to be about designing digital tools so that they don't end up magnifying health literacy gaps. So over the past few years in our own digital expansion, our patient education team is highly focused on ensuring clarity, timing, and guidance and support for patients and caregivers are built into each system that we create. It expands access, it expands modalities, and it expands support for patients' different learning preferences. But again, being mindful of these design considerations is really what's going to help us keep that close connection between health literacy and digital health literacy, really working for people that are using it.
Thank you for making that point. So what you're telling us is that, okay, it's hard enough to be health literate and cancer health literate with regard to the concepts of healthiness and of cancer and so forth conceptually. But then the other layer is kind of a digital literacy. I can't be health or cancer literate if I don't know how to use these tools, if I can't get online, if I can't use this social medium or that social medium. So if I can't use those tools, it's yet another barrier. So powerful point, well taken. I want to we can kind of shift smoothly from that into shared decision making. And I think the key question here with regard to SDM is, in what ways can a cancer patient's health literacy affect their ability to engage in shared decision making, and how might that affect their care and outcomes? And Dr. Dizon, if we could pick on you to get this started, and then Daruti, I know you've got a FACP in there. Dr. Dizon, I know you've looked at a lot of cultural differences and so forth, and you might reflect on those for us. And then Daruti, back to you on how low health literacy might limit engagement with providers. Dr. Dizon, for starters.
Yeah, sure. I mean, I think all of this that we just talked about just builds on how we would love shared decision making to work. It starts with a common understanding of the information that is relevant to whatever the decision is. But it's complicated, and we've learned this through, patient-reported outcomes projects that I've done. Not everybody wants the same degree of autonomy when it comes to decision making, and that might be a personal thing, but it is also very, very much based on culture it's based on, one society that they grew up with, in the culture that I come from in Guam. It's very much a family decision. The individual is important, but it is informed by parents, and it is informed by what that close network also wants for that person. So shared decision making needs to understand, or we need to understand when it comes to it, that everyone is going to enter that space with their own preference of how involved they want to be. Now, if we take that into account, we need to ask ourselves, when it comes to this person and this decision, who else needs to be in that room to hear this conversation? Who else needs to have the understanding of what the latest literature is? And what I've learned by writing blogs and also being on social media and seeing what information takes hold, whether you use, counts in terms of views, or if you look at likes, what takes hold is simple. The simpler the language, the easier to understand. Those are the ones that people gravitate to, with one exception. People are able now to find content online, and this is our bigger problem, that reinforces their own view of what will work for them. So that sort of runs counter to it would not necessarily, but it can run counter to what the best data is out there. But we need to meet that by being as simple as we can. And sometimes what is the struggle is when I try to collaborate with industry partners, for example, or other folks, they want to create a message that targets a single subgroup of stakeholders. And they want to use social media to get that out there. The problem is everybody's going to see the message. So we need to get to a point where a common message is accepted and understood by all the stakeholders, because then we can go into that and hopefully use that as a starting point to help make some decisions that make sense, not for me, but for the person whose life is about to be affected.
So, Don, how do you read the room then? You just gave a great example of, I guess, a Guamanian family. You got to deal with the whole family there, not just one
Right.
person. How does a well-informed, well-meaning clinician read the room and decide how to pitch this?
Well, I would love to hear what everyone's experience is around this. It's so interesting. Someone who wants me to make all the decisions, for example, is very clear about that. I'll do whatever you want. I had that today. Someone was like, whatever dose, you just tell me what to take. Very clear. I don't want a lot, whatever I think you're going to do the best thing for me, just make that decision, and I'm going to do what you think. That's fine, because I'm not trying to, I'm not going to force that person to be more involved than they want to be. The ones that I think you need to ask your question, who else needs to be in that room, are the ones I find who are quiet, who don't ask questions, who just kind of sit there and they nod, and then they leave and they take your recommendation and they leave the room. Because I wonder who are they going to explain to? And whether that explanation is, this is what the doc said, or more likely than not, given what Dana just said, they're going to go back and say, I don't know what they just said to me.
Right. Wow. That's reading the room, I must say. DeRudy, I know you've got a comment in this. And Laura Chambers, if you would weigh in on this one as well, with the shared decision making, I wouldn't mind. DeRudy?
Yeah, no, that was really excellent to hear. My thoughts are basically very aligned with what Dr. Dizon said. In cancer care, our patients and caregivers alike, family members, they're often asked to make incredibly complex choices, whether it's about their treatment or how to manage side effects, how to address quality of life issues. Sometimes all this is happening very quickly. So when health literacy is low, as Dr. Dizon said, patients may just nod along, just staying silent rather than asking questions, not even maybe feeling empowered to ask questions in that moment. People are signing consent forms without knowing what they're signing, not able to think through what treatment options are presented, maybe distinguishing the benefits to them, what a wait and watch approach might be for them versus channeling and choosing an aggressive treatment. And maybe just saying yes without really understanding what they're agreeing to. So some of this comes from, trust in a care team. Some of it comes from trust in family, and some of it, just comes from being completely overwhelmed by what's going on. So I always share one example. We do a professional training for our teams on health literacy, and there's an example from the National Academy of Medicine in which a patient agrees to a total laryngectomy after a conversation with this trusted care team. Then his adult daughter, who was with him, explains the next steps using plain language, and the patient gets really upset because he didn't understand what he just agreed to. He didn't know what the surgery involved and what the post-surgery implications was. So all of this to say that health literacy is really a basis for shared decision making. When patients can't understand fully what's being presented to them, they're more likely to become passive recipients of care. And really, what we're trying to focus on is having active, engaging partnership between the patients and the care team.
Points well taken. Thank you. Laura, I know you've dealt with this, and I wonder if you might kick in a little angle as well on staying with, as we say, guideline concordant care and getting folks to kind of follow what we think are the evidence-based guidelines. Laura, Dr. Chambers.
Yeah. So, I mean, I think it really varies throughout their cancer journey. In my practice, I have people that come in for their initial visit. And in those visits, you can just see it in their eyes, the amount of information you're giving them, what you think is the best plan. And I usually try and start those visits by asking people what they know already. Because I think it helps me understand, like, are they a person they really know why they're here? They've done their research, they're coming in very educated. Because I think then it helps me understand sort of what gaps I need to fill in and how I can sort of allow them to understand the reasons for my recommendations. But then I will often have people that come in and they really don't know why they're here, or they have a cancer diagnosis that really hasn't been well explained or explained to the extent that maybe it should have been. Or so I think I think really understanding where we're starting from is helpful. And I agree with what Dr. Dizon said. I think there are some patients that really, the degree of autonomy that people want in their decision making is really, really variable. And one of the luxuries that you have as an oncologist, or in my practice, because I meet people for their surgeries, I give them their chemotherapy, I know them in their survivorship, is you come to know people and you sort of understand where they fall in that continuum over time. But it's challenging. And I think it's just one of those things that you just constantly have to be. There's times where I'm talking to someone and I'm giving them my spiel and I look and I realize that their eyes are glassed over. They haven't really, I know I've probably said too much, or I need to sort of back up and say, let's see what let's kind of revisit this. So it's hard, but I think, I think trying to understand as best you can what your patients know and what their values are is really important.
So it sounds like you said, what do they know already? So you are explicitly or implicitly establishing a baseline with your patient, because they could know a lot or a little, and that's one sort of axis there. But then you're listening along the way. You have to kind of adjust as you go, right?
Right.
To make that happen. Okay, well, these are very helpful hints. I see wants to add to this issue.
Well, because I love what Dr. Dizon and Dr. Chambers and Duruti just mentioned. And it is a two-way street. It's not just the onus is not just on the clinician or the provider to make sure that they're reading the room and doing all these things. Patients and caregivers need tools. And so it's important that we provide tools to them to say, here's a list of things, of questions that you should always be asking your doctor. That also gives them confidence that even if I don't know what to say, I have a sheet in front of me and I can fill in this sheet to say, hey, doc, what about this intervention? And so giving them some basic questions opens the door for a two-way street and also gives them an empowerment as well. Because sometimes maybe they don't know to ask, are there community health workers in the area? These are the questions they may not know, but if we provide them with a tool that helps them to get those questions, it helps with overall improvement of care.
So those sorts of tools along with clinicians' own observational sort of skills, can establish that baseline and move on from there. Dr. Demenci, speaking of tools, how then, speaking of, we're talking about shared decision making and enhancing patient-provider communication, how then would you have clinicians use the tools to which you referred to sort of move into the cancer care diagnosis and treatment?
Thanks. Before I say anything, I second everything Dr. Chambers said. First off, to have effective cancer health literacy intervention, it has to be first targeted, second timely. Just consider yourself going to see a physician and the physician is treating you as if you have limited cancer health literacy. Some may be offended. Even if it is okay with you, physicians cannot possibly treat their patients as if they all have limited cancer health literacy and then tailor their communication patterns with the patients. In terms of cancer care, it is most useful if clinicians know at the first consultation whether the patient has limited cancer health literacy. With the cancer health literacy test, the patients need to answer only 6 multiple choice questions and immediately get whether or not the patient had limited cancer health literacy.
So that's a
So
first good wave of a test. That's a good screen right in the beginning, eh?
Exactly. Once, ideally, it should be part of patient intake. What is currently missing is the clinical implementation. We have all the pieces that to make it as a part of patient intake.
Got it. So it's interesting in establishing what they know and what they don't know. You can do that qualitatively. There are quantitative tools, as you just mentioned, Dr. Demenci, and as Dana Gaiman Spencer also mentioned. I wonder, Dr. Jackson, Doctors Jackson, Dizon, and then back to Dana Gaiman Spencer. Tell us more, Dr. Jackson, if you would, about this notion of tailoring. We've heard about the disparities and differences in patients and kind of multiple dimensions of health literacy. How do you go about thinking to tailor the communications? What have we learned about doing that well?
So what we've learned is that when we tailor materials, health information, as well as digital health tools, it can improve adherence to using these materials, understanding of these materials, and health outcomes. However, we have to be really intentional when we think about the tailoring. So tailoring just simply just changing maybe the materials to speak to one's identity and not necessarily testing to see, okay, is that really how we should be tailoring it? May not be the best approach. And so what do I mean by that? We can tailor information by various strategies. We can tailor it by sociocultural factors, linguistic factors, peripheral factors like identifiers, labels, images, colors, symbols, so forth. We can also tailor it by having constituents in them, where people see themselves and so forth, right? But we have to find out from community members if that is what they want to see and if that is going to influence influence them to use these materials more. Something that I have learned within my work with community members, so I apply community engagement and most of the work that I do, is that in these tailored initiatives, it's a continuous process. So you don't just create the material first, assume that it's perfect, it's great, and then you're done with it. What you have to do is you have to continue to do these iterative design and testing processes. I mean, right now I can speak to our tobacco prevention health communication initiative that we're doing right now. We're in the evaluation period of our organizational health communication toolkit to promote tobacco prevention. And in throughout, we've been checking in with the organizations, like what's working, what's not working, not to wait till the end of the evaluation period to make changes, but to find out right then what we need to change. And we're actually making changes to some of those materials right now because they weren't, the youth and young adults weren't quite connecting to them as we thought that they would in certain materials. And so that's a part of that, understanding which strategy, like which tailoring approach is the right one, the constant testing throughout, and then doing another round later on. So I think that's really important to recognize in tailoring because we could also, if we just assume that one approach works, we could exacerbate potential stereotypes, potential assumptions about communities and make the situation actually worse rather than better. So that's why I say that we've seen positive outcomes with tailoring, but we can also see harm with tailoring if we're not intentional and recognizing that it's a process and not a one and done.
And maybe if you're trying to tailor to perhaps a stereotype or some kind of inherent bias, that's not going to do you any favors either, right? Gosh.
Exactly. Exactly.
Dr. Dizon, tell us a little bit more about how you're sort of fine-tuning this, the communication with the patients and tailoring accordingly, given your diverse patient populations and so forth. You might still be on mute.
I think in the work I'm doing, let's take the context of a new diagnosis and having to talk about treatment, because I think, the tailoring can have so many different aspects. Dr. Jackson just mentioned one for the COE, community outreach and engagement. When Dr. Chambers and I are in a room, for example, I need to understand what's the baseline that I'm working with. And, I think it's a very simple way to do that because typically they've seen multiple people before they get to me. So it's really that one question: what is your understanding of why you're here today? And that just tells me everything. And it is surprising how many people cannot tell me why they're there.
Did they look to their family member for the answer then, or what?
Typically, the family member will have been the one to do all the Googling, but they will typically also be very curious to see what the patient understands about what they're there. And it just gives me a very direct place to start. And it's very common that I have to start in the beginning before my time comes in to talk about the treatments. But something just struck me about what we're just talking about. I think it was something that Dr. Jackson said, but also building on to something that Dr. Demenci said as well. We talk a lot about meeting the patient where they are, but it does get to a point where, say, we're talking about chemotherapy. I've done my best. They're in agreement to proceed. One thing that hasn't happened in a lot of cancer centers, I believe, we all give information about all these treatments we're giving, and it's collected in a binder that goes through all the supports that are available in our centers, the side effects, the supportive stuff. That is not a tailored document, And if you think about the resources that are required to make a culturally sensitive, culturally informed document that covers the generalities of therapy in a way that will maximize understanding, that is a Herculean task. And I can put it in the perspective of a transgender person going through treatment of cancer. They're not seeing themselves in any of this information as relevant to them. So I think this conversation already has led me to believe that we are actually not only are we not advancing enough in this area, like Dana was saying, we are really just at the start, because there are systematic things in place to help our patients that truly are not tailored. But to answer your question, it's literally that one question that helps set the stage. What is it you understand that we are meeting about today?
Point well taken. Probably should have put it on the wall to make sure it gets asked every time. Dan, I want to ask you a question. I know you're set to say something else, but I'm going to pose a question to you. And while you're answering it, I want to pick on Devlin Jackson one more time to also think about her answer to it, if she doesn't mind, and to Rudy as well. And here's the question. how do you convey matters of risk and probabilities and things like that in cancer care? I mean, even on the prevention side, I'm thinking about HPV vaccine and, what are the odds of getting it and all that kind of protection percentage and so forth. And then with cancer chemotherapy or diagnoses and therapies, a lot of it has to do with risks and probabilities. That to me is a really tough nut to crack in cancer health literacy. What do you have to say about that, Dana? And then Devlin, I hope you've got an answer too.
Thank you for the question,
No
Ball.
prep
I
on
love
that.
it. Before I answer that, and I do have something to say about it actually, but before I answer that, I want to touch on what Dr. Dizon just said because
Sure.
I think he's laughing, but I think he's really hitting the nail into the target. Um, it is really about policy change. And when we as manufacturers are giving materials, I don't like to think of it as tailoring as much as it should be co-creation. And the reason I say that is because, and this gets into the question you're asking, how do you talk about probability and risk? You know, if there is a co-creation involved to say, let's work with communities, advocacy groups, just individuals, caregivers, to ask the question in this package insert, these are the side effects, and this is the profile of side effects and the probability that you will get this side effect. How do you best need to hear that? What makes sense to you? How could we describe it? Now, for legal reasons, we are going to have to give the information the way the information was studied in the clinical trials. However, nothing precludes us to doing a plain language summary that will help patients understand probability, because the likelihood of you getting on an airplane and it crashing, everyday adults understand that, right? And so if you start speaking in categories of terms and things that they understand, the likelihood of you winning $1 million in Vegas. So it just depends. I'm smiling because that would be a wonderful thing. And I don't even know what the likelihood is that you could win in Vegas. But my whole point is that if you change things into plain language, if you say 90% and you change that to say 9 out of 10, right? Just put it in plain language where people understand and test it. Ask the people, does this make sense? That's why it needs to be
Wow.
less about tailoring and more about co-creation.
Thank you for that concept of co-creation and the example you gave. Devlin and Daruti, can I ask you to weigh in on this? And Laura, if you've got something to say about it as well. Again, this risk probability thing in oncology is really important to convey. Dr. Jackson?
So I know that you're asking about this, and I do want to respond to that, but I wanted to respond to Dr. Dizon's point
Sure.
earlier as it relates to even these forms and how we're collecting data and information, because I had just sat on a panel about this 2 weeks ago, and we were talking about health information exchange systems and how when those organizations are gathering all of that information to then be able to understand, the next steps on how they're going to treat and care for their patients and develop certain care plans and so forth, that these systems don't always account for certain data, variables, social determinants of health, lived experiences that should be captured to then know how to have the next step, which is that conversation, right? And these patient-centered interactions. And so back to Dana's point as it relates to co-creation, when I was talking about co-designing and so forth, like we discussed in that discussion about how those systems, oftentimes those systems are created in this very kind of top level space with just certain tech folk or certain healthcare individuals or experts, but not including community members to find out, okay, what are some things that we should be including in these systems when gathering this information, to then set up what that conversation looks like in those clinical encounters. So I did want to just respond to that and just kind of co-sign what others are saying, was that like this is something that we're talking about, but we need to figure out what is the actual solution to make it happen. So yeah, but in regards to your question about risk. So I just want to make sure I heard this correctly. You want to know more about like how do we respond to
How to
risk?
convey. I mean, I think Dan hit on it nicely with the airplane crash, metaphor and so forth. Conveying, it seems to me that in oncology, whether you're talking about screening or prevention or treatment, we do have to talk about risks and probabilities of success or not, how often this is going to work. That sounds like a real tough thing to convey to very variable, knowledgeable people, and is a matter of health literacy and oncology.
So, one thing that I was going to note, but Dana noted it so well, is that, plain language. So, being an affiliate with the Center for Health Literacy, plain language is very important. And I loved how Dana was like, instead of saying this, say that instead. So, instead of saying that maybe it's 9 out of 10 or 5 out of, right? Because that may be more clear. We also know things like visual aids can also be helpful. But another thing that I think ties back to what Dana and others mentioned earlier when we think about emotions in this, what can also convey risk to individuals is when you can put some personal meaning and connection behind that. So if we can convey to individuals like when someone is at risk for something and what they might gain, right, from either engaging in this. And the reason why I say gain is because I know sometimes we have seen in the literature is like what you might lose, but we also know that like loss framing isn't always effective, right, when we talk about risk perception. But when people can see what they can gain, we have seen positive outcomes in that, and connecting that to the risk, right, that could be an effective way in how we can address some more positive, like move into more positive adherence, positive treatment to different care plans.
The statistic can be the same, but you can phrase it in terms of an upside or downside.
Exactly. Instead of just throwing just out the data, coupling it with that meaning to what does that mean to them personally in that context.
Yeah, as I've seen on our chat, the concept of numeracy is something not to be ignored here. Point. DeRudy, something on this, and then Laura, if you have something to add along those lines as well, please. DeRudy?
Again, just double down on what Dana and Dr. Jackson shared. The co-creation piece is incredibly powerful in thinking through what would be most understandable, the visual aids. I think one maybe area that wasn't mentioned, customizing and making it known that how this will impact you personally. So Dr. Jackson spoke really well to that. So that, I mean, to me, that looks like if you, take your treatment on this day, then you may feel well enough on day 7 to do this activity that's really important to you. I think connecting the numbers to values is also important, as best as that's feasible to do. And I think the other last thought I have on this is also capturing uncertainty. So sharing, what we do know, but also being very clear on the parts of it that we don't know. So we're not leaving that room for ambiguity, that this is these are statistics and these are risks that we are sharing with you. And that's all there is. There's also X, Y, and Z that we don't know. And we're also working with that.
Got it. Good. Thank you. Dr. Chambers.
I agree with everything that's been said. And I think I'm going to maybe have a view that's a little adjacent, but I think one of the big things, from being in the clinic and taking care of patients and their families every day with these diseases, I think from a provider perspective, like I want to do the best job I can for these people. I want to explain everything to them. I want them to leave my office feeling like they're equipped with all the information they have to make the decisions they have. And I feel like most cancer providers feel similarly, but I think there's so many challenges, and I think that we want to be able to give this excellent care to people, but there's challenges of time, there's challenges of resources. You have that visit and you go right into the next one and you do that 20, 30, 40 times a day. I mean, I think that that's a big thing. And I think that, I think in order for us to be able to provide that level of care and really get people through and to understand that the things that they need to and leave feeling like they've made the best decision and the care that's like culturally competent and that people can understand. Like, I really think that we need more resources, more time, more people, and I think that that really, we're in a time where those things are scarce and are at risk. And I just think that that's something that really needs to be mentioned as well, because I think we all want to do the best we can, but it's tough, day to day in a clinic when you're managing these things.
Doing the whole tailoring thing that you've all discussed, if we try to do all those things, we couldn't pull that off in 8.2 minutes or whatever
Yeah.
it is these days. I know that.
No.
We want to dive now into social media, and we can take this in a lot of directions, but as an overarching theme here, how have social media influenced our digital health literacy, cancer care, and outcomes? I mean, that's kind of the overarching issue there. And sub to that, of course, is if we lack health literacy, are we more vulnerable to misinformation and disinformation? Just a hint, I want to go Jackson and then Chambers just to get this part started, but I'm going to pump in a couple of questions that have come in that are related to this. And if anybody wants to hit on, can digital effectively meet patients where they are? Does the digital stuff meet the patients where they are, or is there a disconnect? How well can we target different age risk groups through the appropriate social medium? Older, younger, more health literate, less health literate, and so forth. So let's just start with those. And this is for all callers here, but let's just start with Jackson and Chambers. How about that? Devlin?
Sure. So I have a lot of thoughts about this.
Give us your best, give us your top line best ones.
I would say, so the first thing is, social media is there are positives, there's pros and cons. So this is what I would say. Pros in the sense that it is now a space where individuals can share, we as practitioners, scientists, physicians, providers can actually now be a part of the conversations. We can hear, we can kind of lurk and listen and see and hear what everyone's talking about, right? And if we were wondering before. However, those conversations that we're listening in on are a mix of accurate, inaccurate, misinformation. Plus, we also have disinformation. We also now have individuals that are using AI to create posts to communicate information. So that's one side. And then what is confirming that that information is accurate or not accurate, right? Being able to ensure that what I'm listening to is evidence-based, is clinic-based, is actually going to support my health outcomes. The other thing that we have to think about with social media is that some of our social media platforms are driven by algorithms, meaning that however I share, I post, I comment, that's the information that's coming back to me. So if I, as an individual, am not going through the extra steps to verify and interpret the information that is coming through this channel, and recognizing that, okay, because of these different things that I liked and I shared and I posted, this might be why I'm getting this information. So let me make sure that this is actually accurate by maybe checking with some additional outside credible sources, right? Like maybe some medical sources, federal health sources, and so forth. So that's one thing. But then the question
Before you go on, you just suggested, if I may rephrase slightly, that in addition to the tailoring that all of you've discussed already, we're getting algorithmic tailoring, which is kind of not under our control so much, right?
Exactly.
That's scary.
Exactly. And that's where I was going to go next, is that we don't have any power over, how Meta is creating their system, how Instagram, TikTok, and so forth, right? So now we, as practitioners, providers, scientists, we have to critically think, okay, so how do we navigate that? How do we combat that's coming at consumers and support them in their interpretation, their vetting of this information? One possible way is we could think about, different approaches of health communication campaigns. oftentimes our health communication campaigns are going only at, okay, so don't forget to eat this way, thinking about nutrition, exercise this way, get this particular treatment. What if we also think about health communication campaigns as it relates to how you should look at your health information? So those are the ads, or those are the information messages that are coming across through the platforms. In promoting and encouraging folks to think differently about how they are interpreting and vetting the information that is coming through their social media platforms, and not taking it as the one end all, okay, because so and so said it, it must be true. Right.
So we have to support them in kind of filtering out the bad stuff and glomming onto the good stuff. So they may need help
Yes.
in that.
So this is going back to kind of that organizational approach, right? So what are some
Yeah.
organizational approaches that we're doing? And then I think we also need to start thinking about some tools to provide to folks that can help to them to figure out how to interpret, verify information, certain key questions. And there are some models and frameworks that are starting to emerge that are testing and looking at, okay, so what are kind of some of these key things that a person could ask themselves when they're looking at AI or generative AI information or information on social media, to be able to decipher and determine what is
Got it.
accurate, what is verifiable and credible for
Help them
their
figure out what's credible. Thank you.
exactly.
So, Laura Chambers, we happen to know that you've done some work on the reliability of gynecologic cancer information on what, TikTok and Instagram? Let us in on that.
So I want to say first, I agree with everything that's said. I think the reliability issues are significant. And um, I've done several studies now where we've looked at posts that have been created on TikTok, Instagram. We've reviewed the posts for their content and the accuracy of the information. And really across the board, we found that there's really low overall accuracy and of content, especially content that's driven to be educational content.
It's
So
driven to be educational, and that's inaccurate, you're saying.
yeah. And it's challenging because there's not perfect ways to decide if something is accurate or not. So we've used these scores that look at the type of source, if there's bias, where the data is coming from, if those sources are cited, which is really sort of the best thing that you can do with this type of data at this time, or the validated scores. But across the board, we find that there's just significant inaccuracies in educational content on these platforms. So I think it really, really emphasizes that, I think there's a lot of good to social media, and I'd love to talk about that as well. But I do think we just really have to emphasize to patients that, what you see online, what you read, you really just have to talk to your healthcare teams about it. I don't discourage patients from going on social media to get information. I think that there's a lot to be learned from, going through people's posts about their experiences and their storytelling. Like, I think that that's really, really wonderful. But there's just can be a lot of inaccuracies and misinformation for sure.
Laura, can you shed any light on the targets of different social media, how they target different patient groups, whether it be by age, socioeconomic status, education, what have you? Do you see any better or worse matchups?
So my group hasn't studied that specifically, and I don't know exactly like the demographic breakdowns. I do know that TikTok can be like more younger patients, but
Yeah.
I don't think it's universally that way. So I'm not going to get into that because I don't know 100%. But what I can say is we did a study where we looked at, and we just presented this at SGO at their annual meeting as a poster, the Society of Gynecologic Oncology. But we basically looked at clinical trial content on TikTok and Instagram. And we found that we looked at who was posting about clinical trial content and what the type of content was, and found that more providers are on Instagram talking about the trials and the results,
On
and then more
Instagram.
patients are on TikTok talking about their experiences and their ineligibility and their side effects and things like that, which is just interesting because people are posting about the same thing in different places. And I feel like it would be helpful to get everybody in the same places or the same spaces to have these conversations so that you'd be getting that content together. Um,
Mhm.
So,
the point you just made is not to be overlooked.
right,
We're maybe in two different places that are not meeting in the middle.
right.
So Dana Gaiman Spencer, as somebody who says she works with a health literate organization, you must be concerned about this stuff in social media. A lot of media, a lot of different groups, and it's not all accurate info.
It is not all accurate info. However, what I will say, there is, and I think Dr. Chambers was touching on this, there is a role for social media because although the highlight is always the inaccuracies of social media, there are also the stories of people who've connected with clinicians, connected with within health systems because of social media, connected with advocacy groups because of social media. And so I think there is a balance. But what brings to my mind, especially living here in California, is that there needs to be policy. We need to have policy that helps to regulate some of the things that are on social media. We do that in every other thing. For instance, when I think about vitamins and supplements, a lot of them will have a little tag that says has not been FDA approved, right? And so maybe we put little tags or monikers out there where we work with AI providers that say that this gets a moniker if it's not approved or has not been vetted by boards or standards or things like that. Because I think that would then help for people to understand the difference between misinformation, and I think it's important that we define these terms, misinformation and disinformation. Misinformation could be accurate information that as it gets passed on, there are nuances that change within it. So it's like playing the game of telephone. I started out saying star, and then it ends up being a park with a bunch of stars in it. And that's misinformation. Disinformation is purposefully starting out as inaccurate information. So I think understanding the difference between those terms, because that is something that is often, these words are often utilized without really defining the differences.
Point well taken. Rudy, can you shed any further light on the social media issue here? I'm seeing a lot of disconnects and concerns about inaccurate information, whether it be dis or miss.
Right. I would only add that we, as a patient educator, as a person developing content for our institution, working with our partners and doing this, I think credibility, professionalism, these are terms we don't talk about very often in what we do, but really there's a foundation, there's a premise there that we maybe need to revisit a little bit and say, how do we combat some of what's coming out? How do we, in some sense, become influencers in our own right, to be able to combat, I guess is the only word coming to mind, but to just promote the right type of messaging. I've seen it a lot where people are coming in and, well, I saw this on TikTok and maybe you should make education and TikTok video styles. And we're trying to process how effective that is. So we know it's effective when it's coming from certain types of people. But when we look at following of certain hospitals or certain reputed health organizations, the following seems to be much less. This is not anything I've researched. This is just my personal experience with it. So I think there's room to really connect with what is most effective in social media. Why is it so effective? And maybe consider mimicking some of that.
Maybe you learn from it, right? Don, comment on that, the social media. Thank you.
Yeah, I'm also going to give Dr. Chambers an idea for her research.
Good.
I've thought a little bit about, why people tend to gravitate towards some things and not to others. And I would love, Laura, you should look at how engaged people are with the posts that they are making. Because when certainly when I'm approached by colleagues about going on social media, their goal is to become an influencer. And if that is your goal, it's not the correct goal for what we want to do. We have to be driven by altruism. We're there to put good information out, and we are not getting paid for that. So sometimes people abandon social media because it's not viral. It's not going viral. So really good voices are abandoning it because they're not being viewed. What they're missing when I hear that is the opportunity you're abandoning to bring in a community.
Yeah.
And that community is going to build if there's bi-directional interactions. So when I started on TikTok, I would answer questions. And the thing is, TikTok is it's a search engine. People are finding things that I posted 5 years ago, and they're starting conversations about some question I answered 5 years ago. And it's still popping up that someone asked a question about something I posted.
Well, Don,
these things have lives.
Yeah. We just had 2 questions about support groups online. Do you have any comments about sort of self-forming support groups that kind of exchange information as well?
Well, I think they exist because we're not meeting their needs in person. And that might be because if you're 22 with metastatic breast cancer, there's not going to be a lot of people in your local community who fit exactly who you are. That's really the sense of isolation in the real world, the sense of the lack of support in the real world is really fostering a lot of these communities. But at the same time, it's this belief that I am not telling you something that is also driving people towards those silos that we all know exist. Because as Dr. Jackson said, what we like and see and follow determines what we are going to see in the algorithm. Okay. But again, I think it just starts with the basis of why we should be on social media. And that is my position. We want to bring voices of data, of evidence. We should be trying to present them as objectively as possible. And we need to realize that is going to live on. It may be becoming misinformation in time, exactly like Dana just said, because we learn things. But it's really important, the moment you get called out for saying something wrong is not the time to abandon the medium. To clarify that new information has come to light. I got, verified on Twitter during the pandemic. And it was only because I had been posting a lot around oncology, and I was awarded with a blue check mark for a point in time where people needed to know who Twitter thought was providing really evidence-based information. That doesn't exist in any platform anymore,
Yeah.
But again, the goals of why we're on social media, it cannot be to become, viral. Virality shouldn't be our goal. But put it out
social media star.
Yeah. Exactly. Yeah. And engage. That I think is the key. So I wonder if the content that is generating much, it's because there's a fostering of conversation around that post.
Well, I should add that a couple people posed a question and or comment on something it sounds like you just said, which is when patients do come in and they did consult social media, don't berate them for it. Hear them out, see what's going on. But 2 people made that point just now. Okay, I'm going to move into AI, and I want to set this up for you. I'm just going to give you a hint. We're going to go. Let's go Jackson Chambers for starters, but I'm wanting each one of you to weigh in. And Dr. Dumenchi, if you've got any comments about the role of AI from the quantitative standpoint, we welcome that as well. But basically, the overarching question is, how is AI, and maybe particularly the chatbots, how is AI affecting patients' ability to obtain reliable and safe and understandable healthcare information? And are chatbots leaning into disinformation and misinformation? Is that kind of dangerous here? And that's also reflects some of the questions that have come in here as well. And then just one to add in there, what about the potential of AI tools to help patients on low stakes tasks, such as answering certain FAQs and things like that? So I know I threw a lot in there. 2 of the things I mentioned were questions that came in. Devlin Jackson, get us started. AI. Any
Sure.
one or more of the issues I raised, and I do want everyone to weigh in on this.
Sure. So I think similar, I'm going to echo a little bit of some of the things that I've already said, but I think similar to what others have shared and what I said previously is that AI, again, there's positives and negatives to it, right? And so the positive is that it's a starting point for some individuals to be able to get some information around their health care and their health behaviors, or trying to clarify maybe some things that they are trying to understand that their provider has spoken with them about. So I look at AI as like Dr. Google 2.0. You know, when internet came about and Google, it was, so what is Dr. Google doing? And then the patients are bringing that information in to providers and having conversations about it. Well, that's what AI is most likely going to move towards, right? And so I think it's really important to note, to Dr. Vanderpool's point, is that providers are still a trusted source, but we know in this digital landscape that AI is out there, and folks are going to start to get curious if they are not already using it. So the challenge to that is the hallucinations that AI can produce. And so for those, when I say hallucinations, is it's information that's not accurate. It comes off like it's correct, but then it's not, right? So it's this incorrect information. And some community members who are using AI may not be able to decipher what is accurate or not. Not only that, in these generative AI platforms, they will connect you to a source, right? But sometimes those sources are not correct. You know, you click on the source and then you go and check it, and whatever that AI platform told you does not align with the source that it connected with. It may not even be the same title, let alone the data that's in the report. But is everyone taking that extra step to like verify and check that? Are even some of the platforms even connecting it to even a source to do some checking? So that's a concern and a challenge that we have. The other thing with these AI platforms is not only when we're going to them to look for information, but how individuals are using them, as I said before, to create information. Something that I find interesting is that we can't only be concerned only about like the actual words that AI can produce, but also images. I mean, we're starting to see images and videos where folks are like, so and so said, did you see this? And did you and some of us may be able to see and be like, okay, that's AI generated. That is not a real video or a real image or a real person that even exists talking about this issue.
Yeah.
And so that's another thing that we need to think about as it relates to AI. So I know I noted some like the challenges to it, but I think what AI is that it's a starting place that we need to be in partnership with providers to help kind of just, weed out what's accurate. And someone said that earlier. I believe it was Dr.
Yeah.
Chambers and Durruti that talked about like it's more of a partnership in trying to figure out like, okay, what's accurate, what's not, to be able to help inform that process.
Partnership. And by the way, one of our questioners talked about kind of providing a set of credible resources instead of having AI point you in a direction that may not be helpful. Some sort of NCI, NCCN, Cleveland Clinic, Mayo Clinic sort of thing, pointing them to those sources rather than the algorithm taking you somewhere that may not be credible.
And then the last thing, if I could just add,
sure.
what I also appreciate that I think could be a positive with AI in that patient provider conversation is getting conversation started. Some patients, might be coming in and they're trying to figure out, okay, where should I start? But maybe it's what they found in AI based on something that the provider talked to them in the last visit that could spark a conversation to help kind of streamline what are the next steps in their treatment and care plan.
Point well taken. That would work. Laura, what do you have to add? And I was wondering about some of those routine tasks that AI might take over, maybe make your job easier.
I agree with everything that was just said. And I think this has really come so far in the last couple of years. And I think it still has a long way to go. And we're learning more every day about how this fits in. I think there's a tremendous potential for using AI. My institution aren't using it in clinic visits, but some are, to make it so that you can have AI transcribe your notes and you can be more with your patients. Like, that's an amazing use. I think I have used it, you know, when I've tried using it for various things in research or teaching and things like that. There's definite inaccuracies, especially when it comes to linking sources and things like that. So that really has to be taken with a grain of salt. I have patients that are using it, and I think the most helpful thing that I've found is, like, I've tried to empower patients with, like, ways that they could use it potentially. So, like, one example I can think of is I take care of a lot of patients that will have malignant bowel obstructions or bowel dysfunction. They have to be on low fiber diets. Maybe people don't know what that means. They don't know how to eat low fiber, based upon the foods that they like, or, the resources they have for food and things like that. And so I've told people a lot, if you want to be low fiber for your bowel obstruction, you can go on ChatGPT, put in the foods that you have, and have it build you sort of a meal plan of things that you can have that are high protein, high calorie. So I think arming people with ways that they can use it that is productive has been helpful for me. But I think, there's so much research going on in this space. And I think really over in the years to come, it's only going to become more of what we do. And I think, again, like, I like the word of partnering with it. I think that's perfect. The perfect goal.
Hey. I'm conscious of time. I want to move to something quickly. I want to make sure we fit this in. Health literate organizations. That's been mentioned a few times. Uh, Dana, can you get us started on what means a health literate organization? And I might want to go to Dizon, Chambers, and Ramchandani as well on that issue. We're short on time, so give us the best on health literate organizations.
A health literate organization is just simply an organization that is enabling access, equitable access for information, for
Mhm.
people to be able to find, use, and inform on health information. That is literally the definition of a health literate organization. And I will say there are some gold standards that
Mhm.
there is a gold standard for attributes of a health literate organization. And actually, it was published years ago in the National Academy of Medicine, where they have the 10 attributes of a health literate organization. And I will mention three of the 10 of the attributes that are really important is starting with leadership, making sure that the leadership of an organization is bought into health literacy so that it gets embedded into structure and operations. And so that's actually why here at Genentech, we actually have health literacy as one of our strategic pillars in our Center of Population Health, because it is important that leadership and that it becomes embedded into the organization. So that's number one. And then the second one is access, making sure that patients can have access. We have an entire, for our commercial organization, we have as part of our strategy patient access, so that every role within this commercial organization is seeking to make sure that patients get equitable access to our medicines and the information that we provide. And then the last one, which I think is of the 10, is also really important, is this notion of a range of skills, meaning that an organization needs to provide a range of skills, recognizing that there is no one panacea to do everything for individuals. We talked about this, like what we put out is not tailored appropriately, or it's not co-created. So it's making sure that there are a range of skills, and it's not just ethnic and cultural, it's also geographic. It's also generational. I think that is something else. What works for my
Mhm.
niece at 30 is not going to work for my mother. And so being able to have a range of skills and being able to print things out. Yes, people still use print. My mother is one of them, and she prefers large print. So a range of skills when we are addressing health literacy is important as well. And if you're going
So
to be a health literate organization.
are you, is it fair to say you've taken that on as a corporate commitment, your
It,
company?
I don't know that it is a commitment as much as what we like to say it's becoming part of our DNA.
Okay.
It's who we are. It's who we are, recognizing that this is what we do. And we have a mission here that says doing now what patients need next. And so that is the doing now what patients need next.
Thank you. Dr. Dizon, what means to you then health literate organization?
Yeah, I mean, I think Dana said it right. I mean, and we all sort of state we do that, right? It's organizations that provide patient-centric care using language that they completely understand. When I was at Brown, although we were not an NCI Comprehensive Cancer Center, we mirrored what the comprehensive cancer centers were doing with community outreach and engagement programs. We had that. We had a patient family advisory councils, both of which were helping us develop resources that were needed in the center, but also ensured that we were speaking in a language that everybody understood. So, for entities that embrace this idea of patient-centric care, by definition, should be embracing health literacy as one of the ways to achieve patient-centric care. And I'll leave it there.
Got it. Building it into the DNA across the board ain't a bad idea. Daruti, a further point on health literate organizations.
Yeah, I agree with everything that was said. I think a key part is embedding these system-wide practices that can look like a number of different things given our truly competing priorities and resources at this time, but it could look like investing in plain language training for all patient-facing staff. It could look like supporting patient care teams with a health education resource team, which is what we have at City of Hope, and recognizing every diagnosis. It's like integrating into the culture, the DNA, recognizing every interaction someone makes from diagnosis up to billing to everything is affected by health literacy. So well-designed patient education has a standardized role throughout any health literate organization. And I'll add one very specific thing that I've found to be really critical in the last few years in my work is having health literacy experts or a high level of focus on any safety, patient safety initiatives or quality initiatives, because we're pushing out mission critical information in those settings. And so having it, giving it that opportunity to be tailored, including patient partners on those committees as well, is something that we have ingrained in our culture. And it's been highly effective in reframing what we might do independently without that feedback from a health literacy expert and from patient partners. So I will leave it at that, though. There's a lot more to say.
Into your DNA as well, maybe even your RNA. Who knows? Let's see. Okay. Again, I'm conscious of time. Here's what I want to do. This is a closing question for everyone. Please answer it in a sentence if possible. Okay. And here's the question. It's not a standard one. The question is this. I wish Cliff would have asked me to say something about X, or I meant to say something and I didn't get a chance. Leave us with your final thought on health literacy in cancer care, something that you wish you had said but didn't get a chance to, or something we should have asked you, but we didn't. Devlin Jackson will set a great example for a sharp nugget of wisdom here. What is your one thought, Devlin?
So the one thought that I will leave with is being in the state of Maryland and at the University of Maryland, the School of Public Health. The Center for Health Literacy was was designated several years ago as the Consumer Health Information Hub. And it was established as a mandated space to ensure that organizations across the state practice plain language health literacy principles to ensure public health information is provided in plain language, accessible, and preferred languages to improve health literacy across the state. And I just want to say that that's a great example of how they move to get policy, like make health literacy a policy standard for the state and for organizations.
Point to take home. Thank you. Dr. Demenci, what would you like to leave us with in just a sentence or two, please? You might be on mute.
Thank you. Something like cancer health literacy test 6. It takes no more than a minute or two, making it a routine patient intake procedure, like vital signs. It will provide the clinicians the tool that they need to minimize the impact of limited cancer health literacy in patient care.
Aha.
The impact of those changes will provide opportunities to empirically test patient experiences about care journey and health outcomes. I think EMR platform is ideal to accomplish those goals.
EMR would be. Thank you very much, Dr. Dumenchi. Dizon, Dr. Dizon, what do you got? What's one more gem?
All right, so I wish Cliff Goodman had asked about the association between educational attainment and health literacy, because they are not synonymous.
Point very well taken. We may have broached it on the edges, but another point to drill into it some other time. Thank you. Daruti, what do you have for us? Final thought.
Final thought, I think health literacy really comes down to respect, patient-centeredness 100%, but respect for people, respecting our patients and caregivers' experiences, respecting what they're going through, their cognitive, emotional load, and really their right to, we talked about shared decision making, really their right to understand what's going on and participate to the degree they are comfortable participating.
The rights to understand. That's a great catchphrase. Thank you. And a little bit of RESPECT, as you mentioned at the outset. Thank you. So, Dana, what's your final thought for us?
The final thought is the speed of innovation is moving faster than a lot of organizations and people can keep up with. And just being cognizant of the fact that health literacy is not a destination, it is a constant journey. You don't become just a health literate organization. That is an ever evolving thing based on the fact that innovation continues to evolve.
You're never done. Thank you, Dana. Laura Chambers, Dr. Chambers, a final thought.
I think I would just encourage, patients and providers. I think, like I say to my own patients, I think if you have a question or you're not sure or you leave and there's something that you feel like wasn't explained or you don't understand or you need more, like just to ask, I think the care team really, really does want you to feel like you have all the information you have to make the right decision. And you shouldn't feel bad to bring up something in the office that you've seen on social media or Google or AI. That's, I think, what, not being afraid to advocate for yourself to get the information that you need to make your decisions.
Well stated. We really have to be receptive and open with our patients. They're coming at us from different directions, different baselines, as we said. We got to do our best along those lines. Well, if you thought you wanted to know something about information to insight, reimagining cancer literacy online and related issues, you came to the right place. And I want to thank Laura Chambers, Dizon, Levant Dumenchi, Dana Gaiman Spencer, Devlin Jackson, and Daruti Ramchandani. You laid it on us in 90 minutes. It was chock full of information. We wish we had more. This is such a fast-moving and important issue. I'm rather certain we're going to come back to you for more at some place along the line. Thank you all very, very much for your time, your expertise, and your wonderful insights. Thank you.
Thank you, Dr. Goodman, and thank you all the panelists.
Okay, thank you. Okay, we keep moving right along here. We're now going to move to 3 best practices presentations. The idea here is we have just discussed a whole raft of issues with regard to health literacy and cancer in particular. And in the order that you now see, we're going to have 3 presentations. Each one of them is going to go for about 10 or 12 minutes. We won't have time for Q&A, but you're welcome to put comments into the chat and so forth, or the questions, just as a matter of record, because I know we've had so many good comments along the way. And so the order is going to be Reinhardt, Waxberg, and Drake in that order. And starting out with Tim Reinhardt. Tim, remind us who you are, what you do, and give us your best 10 or 12 minutes. Tim, best practice.
Got it. Hi, everyone. I'm Tim Reinhardt. I'm a medical writer in the Patient Information Department here at NCCN. So, the patient information team works to ensure that clinical information that the regular panels that include in our clinical guidelines is translated into patient-friendly language given the appropriate context. This is put together into the NCCN guidelines for patients that are each tailored to their own disease or population's needs and priorities. Like the clinical guidelines, the patient guidelines are free to access on nccn.org with the support of the NCCN Foundation. So I'm going to move on and define health literacy in case you haven't already heard it. But health literacy is an individual's capability to understand health information. It's informed by the social determinants of health, which we know is education, age, socioeconomic status, and gender identity. But put simply, a person's capability to understand what cancer treatments are available to them is affected by where they grew up, what education they have, their income, and even their personal beliefs. Health literacy is also affected by the health of the patient receiving the information. So if someone is receiving a life-changing cancer diagnosis, they're not going to learn or be able to respond as effectively to the new information about a medicine or a treatment. So we, patient information, have made a decision to design the patient guidelines with health literacy in mind. Much like the clinical guidelines, we derive our information based on research. And the research shows that most patients will want information that is simple and to the point to aid in their decision making. Therefore, we strive to write the guidelines for patients at a 6th to 8th grade reading level, which is the average reading level for adults in the United States at this time. The imagery is also utilitarian, which includes just the information that the patient wants to know. Much like the clinical guidelines, we strive to use language that is inclusive of all peoples and lifestyles. This means that we use person-first language. So it's not a cancer patient, it's a patient with cancer, for example. This allows the reader to feel a little less like they're in a box because of their diagnosis. Finally, we use a design that focuses on readability and focus with lots of white space. Health literacy research indicates that making the text a bit larger helps accommodate most readers, so we followed suit by doing that in our content. The design also features very few embellishments or elaborate pieces to prevent the reader from getting confused or losing interest in the guidelines. So this is an example of health literate language that we use in our books. This is the definition of myeloproliferative neoplasms. And basically, we break down the word into its parts and just kind of define it and then recontextualize it all at once. So it's almost like a dictionary entry. This is an example of health literate design. So we use silhouettes of people rather than an actual person, and we try to stay away from the very good medical photos that you see in textbooks to avoid, well, frankly, grossing people out. But also, we keep them out of the equation because they serve to mainly help clinicians rather than the public. The image on the left shows a picture of symptoms of a person with a clotting disorder might expect. And the image on the right is a standard illustration that we all are familiar with, but the caption itself is a little bit more directed toward the patient. So this slide explains in broad strokes the patient information department's workflow for the patient guidelines. So first, each patient information team member is assigned a guideline based on their expertise and knowledge, and they're also included on all of the messages and in the panel meetings for a particular panel. So we sit in on the meetings, we understand the justification for decisions made, and we learn what the ongoing thinking is beyond the revisions that we'll be presenting in our books, in our guidelines, that is. Then we'll make the relevant changes to the patient guidelines based on what we've learned. From there, we'll send the manuscript of what we've done back to the panel for review, including the patient advocate. A patient advocate reviews every patient guideline when possible, and we always include their feedback and make sure that it's readable from a patient perspective as well as accurate from a scientific perspective. After the review returns, we copy edit the manuscript in-house and make sure the last final changes to the text that are necessary are made. Then the manuscript goes into the queue for a design team to lay out. This can take up to a couple of weeks, depending on their workload. And once it gets laid out again, we have another review process where the copy editor is given an opportunity to go through things. And then whoever wrote the book, or the content rather, will go through and make sure that everything is squared away and good. Then the product will be posted on the website on schedule. But we don't stop there. The guidelines for patients are constantly being refined and changed based on the latest evidence that we can collect. Primarily, our information comes from a voluntary survey that is, there's a link included in all of our content. But before writing, the patient team member will pull the relevant data from the survey and include any valid feedback in their revision. In addition, we held a focus group last year about the readability and usability of our content, and what we learned has guided our 2026 design and content development processes. We hope to have more focus groups in the future so we can continue to make the guidelines for patients as best as they can be. Finally, as of 2026, we have all of the guidelines for patients updated on an annual basis rather than on a 1 or 3 year cycle as was done in the past. This ensures that the content that the patients are reading is always the latest and greatest information from NCCN experts when they need it the most. So if you were listening to the panel, you heard a lot about mis and disinformation, and the NCCN guidelines for patients are not immune from that. We are working to combat health misinformation by providing our information free of charge. We offer an option to purchase bound physical books of the guidelines, which cost a few dollars to pay the printer, but NCCN and the NCCN Foundation makes no money from the production of these guidelines. We have no agenda to promote, just facts. We hope to continue the fight against misinformation by expanding distribution of our guidelines on the internet. They would be in the form of websites for each cancer type, formatted similarly to the books that we already provide, and available in a searchable format along with the accessibility features that go along with internet browsing in the modern day of 2026. That is all I have. Thank you for your time.
Well, Tim, thank you. Before we let you go, though, Tim, you made mention of focus groups
Yes.
that you learned from the focus groups. Would you mind sharing with us maybe a thing or two that you did hear back from them, and whether or not you were able to incorporate that feedback?
So some of the main feedback we had was that a lot of the focus groups didn't want to know specific details about like biologic processes. They wanted to know more things that like, how did it relate to me? Like, what does this matter to me? And also, they didn't necessarily need to know what every abbreviation meant. They just wanted to know what it is, how it's being used to help them.
Got it. Thank you very much.
Thank you.
Wanted to make sure we nabbed you on that, and wanted to make sure that you heard the focus groups and did something with it. And by gosh, you did. So that's
Absolutely.
good. Thank you. Thank you. Let's move now to Elizabeth Waksberg. Elizabeth, you're an advocate, and you're going to tell us a little bit about how you came to become an advocate and what you do. And very interested in hearing your take on health literacy and cancer care. Elizabeth.
Hi, how are you?
Great.
Okay, yeah. So I was diagnosed with stage 4 colon cancer on April 14th of 2019. I am lucky enough that this coming July 1st, I will be 7 years cancer free. I feel incredibly lucky to have a platform that I have on social media to be able to talk about all of the things that I went through and all of the different stages of the symptoms that I felt, the dealings that I had trying to get a diagnosis, and then now in advocating for colonoscopies and for people to know how to pay attention to their body and also how to speak to doctors from a patient's perspective. I grew up in a household where my father was a pediatrician, so I have always gone to the doctor. I have always been fine going to the doctor. I joked as a child that I was a milk of magnesia and Desitin baby, so I, from a very early age, had stomach issues. As an adult, I went to different GIs trying to get a handle on what was happening with me. And I tested negative for celiac, and I was given sort of the broad IBS diagnosis. My symptoms slowly started to change, probably around 2015. And I went to see a doctor. I went and saw a new GI who did a breath test and then wanted to do a colonoscopy because he thought that I might have a mild Crohn's or colitis. But he was leaving the network the next week. So after we did the appointment, my insurance called and said to please find another doctor. So I went and I got a new referral to a new doctor that was in that same office. I went to see that person who looked at what the previous GI had done. They said, you tested positive for the bacterial overgrowth. You have IBS with bacterial overgrowth. I want you to take an antibiotic every night for 6 months to a year. And then he said to me, this is what I think is wrong with you. And I'm never wrong. So this is what's wrong with you. I did not like that speaking point, and I also wasn't comfortable taking an antibiotic for that long. So I then put in to see another GI. With my work schedule, this was happening like once a year. I went and saw the third GI, and they said, well, I don't think it's Crohn's or colitis. We can do a colonoscopy, but I don't think it's going to show us anything. And then again, my insurance called and said, this is the medical fee, this is the hospital fee, this is the doctor fee, this is the propofol fee, and then you owe 10% of whatever the colonoscopy costs. And I said, oh, okay, great. Like, what is that? And they said, well, we don't know until it's billed. And so my GI said, well, why don't we wait until your symptoms come back? I went an entire year without any symptoms. On March 1st of 2019, I felt like I'd pulled a muscle in my side. I Googled my symptoms and it told me that I had gas. And my sister later joked that I'm the only person that Googled symptoms and it didn't tell her that she had cancer. I then went to get another referral to a new GI because the GI that I'd seen last didn't respond to my messages. The person that gave me the referral said it was probably dairy. And when I was later diagnosed with colon cancer, my sister said, well, at least you can still eat cheese. But I then got another referral to another doctor, and I went in and saw the GI that ended up diagnosing me. He saw that I'd had bad blood work in January from my physical, but nobody had followed up with me to do additional testing. I went home. I woke up the next day in the worst pain I'd ever been in. I drove to work because that's what you did. I couldn't stand up straight, and they sent me home. On my way home, my GI called and said that the inflammation levels in my blood were so high that I had to get a colonoscopy on Friday. The next day, which was Thursday, the 14th, he sent me to get a CT scan. My dad flew in to meet me. And when I started the CT scan, they said, when was the last time you ate? And I said, oh, last night, because I'm getting a colonoscopy tomorrow. And they said, oh, do they know you're here? And I said, yes, they sent me. And he said, okay. And then left because I had a blockage and things backed up behind it. So on the way home, my GI called and said, oh, you're driving, I'll call you back later, which I knew was not good news, but I was also in incredible pain and very nauseous from the contrast. So the way that I found out that I had stage 4 colon cancer is that I was sitting on my bathroom floor throwing up the contrast, and my dad came in with my phone on speakerphone, and my GI said, I'm so sorry, but you have a tumor in your colon and spots on your liver and you have to go to the hospital. My mother passed away from non-Hodgkin's lymphoma of the bowel when I was 4 months old. And so even though related, my poor dad whispered, "It's happening all over again." And I felt so incredibly bad for him. As a 2-year-old, I had no submandibular salivary gland. So he had been through this. Me as an adult, I was 38 when I was diagnosed. We went to the hospital. And that's kind of when I learned very quickly that doctors and nurses and medical staff, who were incredibly lovely, didn't really know necessarily how to talk to me specifically. My night nurse told me a story about the time that they thought that she might have breast cancer, but don't worry, she was okay. And I sort of went, oh, this is people just don't know how to speak, especially to young people with stage 4 cancer. The next day when I went for my biopsy, the nurse looked at my chart and looked at me and said, "But you're so young and pretty." And I thought, well, I don't know that cancer cares. And the anesthesiologist sat down and said that he was going to take off his doctor cap and that he just felt a little weird because I wasn't that much older than he was. And I didn't know if I was supposed to apologize that this was weird for him. And I sort of realized that you could find that comfort and sort of exchange of information around other patients that had been through what I'd been through. The problem became that I didn't have a ton of people to follow because I was a stage 4 patient who then had a complete response after only 3 rounds of chemo. I had to do the last 5 after my surgery, but the pathology from my colon and liver resection showed that I'd had a complete response. And I live in this space of a stage 4 cancer patient who doesn't have cancer, which is sort of a strange space to live in. I know that one of the panelists, I'm so sorry, I don't remember which one, mentioned that they like to ask their patients what they know is happening. And from a patient perspective, I will say that being in the hospital and having the team of the colon team come in and having one of the doctors ask me that question, I didn't love it. I think that maybe in a one-on-one situation, it would have felt different, but I was very uncomfortable in that situation of having to talk about what I was supposed to know was happening with myself. What I did love, and one of my favorite people, is my liver surgeon who came in by himself, sat down, pulled up my scan on the screen, turned it to me, and said, this is what I want to do. And then he looked at me and he said, "Let's cure this thing." And I said, "You can do that?" And he said, "We can try," because nobody had said anything close to that previous to that person coming in. I wanted to also talk about in the beginning, for a lot of patients, just hearing the word cancer, I have a lot of blank spaces from the beginning of that time. I think finding ways to have notebooks and pens for patients to have on them at all times so that they can write down questions that they have. They can write down answers. Obviously, people can do it on their phones. I prefer pen and paper. But I tell people all the time to make sure that they have a notebook with them. The beginning is so overwhelming with information. I tend to have the same conversation over and over again with people. But what I found my footing in was with social media, and that started during the pandemic. Obviously, a lot of people were online. And I made a TikTok account just to watch other people's videos. I never expected to start doing cancer advocacy from there. But there was a trend going around about outfits, and I made my first video about the different outfits that I wore to chemo. And it got a lot of views. And I slowly started making videos about what I had been through. And I found that younger people were on TikTok, and with colon cancer specifically, it's now the #1 cause of cancer death for people 20 to 50. And I found an important group of people to be able to speak to, and that you can give them help with how to talk to their doctors, how to ask for a colonoscopy, how to share things that they maybe aren't super comfortable sharing. I learned very quickly that all of your vanity and dignity kind of goes out the window with colon cancer. So being able to talk to people about looking in the toilet after they go to the bathroom so that they can get a baseline and see if there's something going on, to share what those symptoms are. And I get messages now from people saying, I advocated for myself to get a colonoscopy. The doctor said I was too young, and I was able to get a colonoscopy, and they removed precancerous polyps, and they said, you saved my life. And so I think that for as much misinformation and disinformation that's on the internet, it is, for me, if one person doesn't have to go through what I went through, I hope nobody ever has to have oxaliplatin ever again in their lives. It is awful. And so for me, being able to use social media to reach people, and then also being able to cultivate relationships with people, and figuring out that how you speak to people online versus how you speak to people in person. There's a woman that I met with recently who was diagnosed with stage 4 colon cancer while she was pregnant with her second child. And she casually brings up ivermectin, right? And my instinct is in my head is to say, what are you doing? Why would you do that? Don't do that. It's not going to help. But I also know that that approach isn't necessarily going to get through to the person who is so desperate to find any way to stay alive. So I sort of call it the gentle parenting of cancer advocacy, which is having that conversation and being able to say, I understand that this is how you're feeling, and how do we talk to your doctor about the things that you want to integrate into your medicine. And I just feel very grateful that I am able to use social media to have these conversations and to get people to understand. The GIs that I've spoken to lately have all said that the age for colonoscopies is not being lowered, but the amount of the threshold for being able to ask for a colonoscopy is something that can be lowered.
Elizabeth, I'm kind of
Yeah.
still gasping at the first part of your discussion. I was
Yeah.
kind of unable to catch my breath, if you don't mind my saying so.
Yeah.
So you basically started with worst practices and you
Yes.
moved into best practices.
Yes.
And good gosh, I just appreciate all the points you made about your experience, including chemo outfits, and I imagine there are accessories that go with them, and your experience on social media and your presence on TikTok. Um, how do you stay so strong? Can I ask you that? I'm sorry, if you don't mind.
No, it was tougher in the beginning. I think 7 years out feels a little bit different. I at different points had doctors telling me that I had to stop. And it wasn't online. It was because I am a stage 4 colon cancer patient. Anytime somebody knows somebody or is diagnosed, I get reached out to multiple times a month. Can you speak to, so my brother, my sister-in-law, they were just diagnosed with stage 4 colon cancer. I told them that you were fine. And I always have to say, yes, but right at the moment, I'm an exception to a pretty solid rule. But there are more and more people surviving stage 4 colon cancer. And I'm hoping in 3 years to join the 10-year cancer-free club. But I have found a community. I'm wearing my colonoscopy enthusiast
Yeah.
shirt. My friend Brooks and Sarah created world-class clothing, and they're a nonprofit, and they provide colonoscopies to the underserved. So Brooks lives in North Carolina, and the first rounds of colonoscopies went to the migrant workers who had had positive stool tests, but they couldn't take the day off of work. They couldn't afford to pay for a colonoscopy. And this company, World Class Clothing, they now pay for people to get colonoscopies.
Great. Elizabeth, just as a final word,
Yeah.
do you have like a bottom line sentence or phrase that captures being a health literate advocate?
It's exhausting.
Okay.
And I think there's a video right now of mine that's going viral on TikTok because a woman, she actually, thankfully, her child, CPS took custody today. She wanted her child with leukemia to try China Gold or something instead of the chemo that has a 90% success rate. And it's very popular right now on my TikTok account. So I think that it's a balance of the work that you do to advocate and then the work that you do to combat misinformation.
Thank you. Elizabeth Waxbird, we're so grateful for this, and we hope you'll let us know about that 10-year benchmark if you don't. We are
I
rooting
will
for
shout
you.
it from the rooftops.
We're here to listen. Thank you so much. You're
Thank
so
you.
generous to share your story and your insights. Thank you so much, Elizabeth.
Thank you.
Okay, well, after Elizabeth, we're going to move to Richard Drake, who's a professor at the University of Central Florida School of Communication Sciences and Disorders. And Richard, what do you have for us? You're wrapping up a great day for us.
Well, let me say, what a compelling story we just listened to, isn't it? It really motivates us to
Wow.
do the work that we're doing. And I'm really grateful for Elizabeth that she's had such a wonderful outcome. I'm a speech language pathologist by training. So for 40 years, I've been working with patients with communication disorders. My primary area of expertise is voice disorders. And within that area, I've worked with patients with head and neck cancer. So when I received the invitation from the Cancer Network to talk today, I thought I would talk in general about some of the issues related to digital health literacy and try to frame it a little bit within the area of head and neck cancer, since that's an area that I'm familiar with. And so I think one of the things today that I think we take away from today is that, now more than ever, patients have access to information, but they don't necessarily have improved understanding of that information, nor do they have the ability to act on that information. And so those are some of the things that I'd like to talk about today, ways that we can improve both understanding and actionability. See if I could advance. Can you just advance the next slide for me, please? Thank you. So as we've heard today, many adults struggle with health literacy, right? And so there's some recent data that's come out from the NCCN, National Center for Education Statistics, that shows that about 28% of adults struggle with literacy tasks, and about a third of adults struggle with problem-solving tasks. So when you think about reading and writing and then trying to problem solve information that's given to you, and you realize that, upwards of 100 million English-speaking adults in the United States struggle with some form of limited health literacy, we start to realize the magnitude of the problem that we're facing with all patients. And this problem is magnified, I believe, in patients with cancer, particularly head and neck cancer, which is the population that I have worked with. Next slide, please. So we've talked about digital access, and as I've said before, digital access isn't enough. And so one of the things that I've learned over the years of doing research in this area is that patients can access the information, but when they get to the websites, for example, the website information isn't readable. Or if we give them an information packet, like a patient education brochure, that information isn't readable. And it's not because the people that wrote it intended it for it to be unreadable. It's because they didn't take into account the fact that they were looking at a person, or that their target reader was somebody who may in fact have limited health literacy. And one of the things that I try to impress upon my students when I talk about this topic is that rarely, if ever, does a patient tell you they have limited health literacy, right? In many years of practicing, I've had maybe one patient tell me up front, hey, Dr. Zrake, I struggle with health information. Most of the time, I have to deduce that myself. And frankly, until I got into this area about halfway into my career, I shudder to think of how many patients I may have missed that had limited health literacy, and I didn't recognize the signs. And it's not unique to me. Many studies have shown that most healthcare providers miss the signs of limited health literacy. So we can't expect our patients to tell us. We have to be looking for it, and we have to check for it. Next slide, please. So when you think about digital healthcare, right, and we think about all the additional skills that are required. So if somebody is visually impaired, if somebody has mobility issues navigating with a mouse to get to the screen or the cursor, if they don't know how to navigate through the web page, if they don't know where to find the information on the web page, and in fact may be accessible, but then there's an overload of information. And in fact, it may provide so much information that the patient turns away from the information because it's just too much and they shut down and they can't process it. So while there's a lot of information and you would think that that would be good, it's good for somebody who's health literate. It's not good for somebody with limited health literacy. So then we have to think about what can we do about that as providers and as systems. And as we've talked today, we've talked about both the personal health literacy and the organizational health literacy. So when we think about ourselves as clinicians, those of us that are, we have to think about, the information in terms of how we present the information, how we listen to the patient's questions, the patient's concerns, their family members, the whole unit that we're treating. We have to have the emotional skill and development and maturity to deal with patients in terms of establishing rapport and empathy. And then we also have to enable patients to have behavior that will enable them to follow through on the information that we present to them. And all of that is on us as the healthcare provider or on us as a healthcare organization. It is not on the patient. And I would say this has been the biggest shift that I've seen in 4 decades of practicing. When I started practicing speech language pathology, when people talked about health literacy, which was rare, it was all the responsibility of the patient to be more health literate. Now, thankfully, with Healthy People 2030 and prior to that, the shift has now really become on the provider and the healthcare system. And I think that's where it always should be and hopefully will continue to be. Next slide, please. So now if we add cancer as a diagnosis compared to some other diagnosis, it's a very emotionally burdensome diagnosis, as we just heard. There's a lot of information. Patients fear the word cancer. My father died from stomach cancer when I was 12 years old, and I distinctly remember that impact that it had on my family. And then if you take it to something like head and neck cancer, which I've dealt with before many times, you now have a patient who is now going to lose the ability initially after surgery to verbally communicate, which in and of itself is traumatic. And then you think about what's the impact of that burden on the patient's ability to communicate, right? So earlier people were talking about, reading and writing and using notepads and writing things down on a piece of paper and using their phone or their iPad. Well, sometimes those work, but certainly it's not the same. We couldn't have conducted our business today not speaking. And so you have patients who have this tremendous fear and all of these questions, and they want these questions answered. But now they don't have a verbal ability to do that immediately post-surgery. So it adds an additional burden that perhaps other forms of cancer may not add. But it creates a cognitive load, it creates an emotional load, and there's a barrier that the patient shouldn't have to overcome. It's something that we as the provider and as the system should help them to facilitate. Next slide, please. So I found this study most recently. Actually, I had this presentation prepared about a month ago, and then about a week and a half ago, this study came out where they were looking at patient-reported outcome measures for head and neck cancer, and they did an analysis of the readability of those head and neck cancer PROMs. And as it turns out, they looked at about 30 of them, and most of them exceeded the recommended reading grade levels, right? And we mentioned earlier about the reading grade levels being, somewhere between the 5th and 7th grade reading level, and most of them exceeded that. And also, in the development of those PROMs, when they looked at the development of the PROMs, readability was not even taken into consideration as a construct in the development of the PROMs. Now, this is not unique to PROMs for head and neck cancer. I've done about 24 studies looking at PROMs in speech language pathology and audiology, and we have the same results in our discipline. So not casting aspersions on those who do work in the area of cancer. I think this is just a universal problem that needs to be continually addressed with research and advocacy. Next slide, please. So treatment decisions, which we've been talking about today, and we just heard recently, from our speaker, Elizabeth, health literacy can certainly shape treatment decisions. And so this study that just came out again recently this month in the European Archives of Otolaryngology found that 52% of patients who had adequate health literacy chose surgery versus 25% who chose radiotherapy only. So what they found is that the level of health literacy influenced the treatment decision that the patient made after it was presented to them by their physician. It also found that higher health literacy was linked to a better quality of life. So it's one thing to talk about health literacy in terms of what does it do to help the patient make decisions, but then those decisions also are going to shape ultimately what the patient's quality of life and those around them are in terms of their lived experience. Next slide, please. So as I mentioned earlier, we have a systems issue with health literacy, right? So for many years, I was at the University of Arkansas for Medical Sciences in Little Rock, which is an academic health sciences center. And I remember distinctly one year they spent over $1 million just changing the signage at the academic medical health center so that patients could find their ways to the clinic, knew which floor they were on, where they needed to go next, so they wouldn't get lost because it was a sprawling complex. And they did that because patients would pull up to campus, get lost, get back in their car and go home. So they had patients who were getting lost to follow up. They weren't getting tested. They weren't getting the procedures that they needed. And ultimately, some of them died. And so they took the money and they invested it in this campaign to just make the whole facility more easy to access and to navigate. And they found that they ended up saving like 6 times the amount of money that they spent on the signage just to get better care. And of course, then there was the human toll, which was a very positive human toll in terms of not losing patients to follow-up care. And so when you think about what our patients' burdens are, right? So too much information, too fast, perhaps too complex most of the time. Our responsibility as a hospital, let's say, is to make sure that the information is clear, consistent, and usable. And whether that's at any point that the patient accesses our system, physically, they're on campus, or they access it through phone lines, they access it through the web portals, the e-portals, and the other things that we've been talking about today. Next slide, please. So we have to think about how we're going to design this digital communication for real use. And I think all of us have probably gone to a health website looking for information, and we're all educated in this area and we know better. And many times we get overwhelmed because the information is not presented in a way that's easy for us to navigate. It's also increasingly difficult to know if the information has been vetted and how accurate that information is. And there are ways to do that. There are metrics and ways to analyze the suitability of those websites in terms of being vetted, not having commercial interests influencing them, and so on and so forth. But you can't expect the average patient or their caregiver to be able to discern that information. So on top of the issues such as using plain language and creating support networks and support decision trees, and the ability to check for information, we also have to make sure that the information that's provided is designed in a way that patients can use it in the real world, so that when they walk in the door and they see us and they ask us these questions, we know where the information's coming from and we know how to respond to those patients. And I was struck earlier by the comment that was made by, I believe it was one of the physicians, who said, just because there's no questions doesn't mean the patient doesn't have questions. And this is something that I teach my students all the time. Don't assume that if somebody's not asking you a question, it doesn't mean they have one. It probably means they have one, and either they don't know how to formulate it or they don't think you're a person that's going to receive questions well. And so you need to make sure that they understand, using Teach Back or Ask Me 3 or 5 steps or any of those kinds of interventions to make sure that patients understand the information that we're presenting to them. And that's our responsibility to do that. Next slide, please. So one of the things I wanted to end on was this issue that, Aaron Bailey had asked me if I would talk a little bit about my most recent area of research, which is using AI to improve readability of healthcare information. And so this is an example of a study that we just published this month. And it's not in the area of head and neck cancer, but it's in the area of voice disorders. And it was looking specifically at a voice disorder called spasmodic dysphonia, which is the voice disorder that Robert F. Kennedy Jr. has. And so what we did is we went to the websites and we asked the websites to provide information about 3 basic questions. What is SD? What is the treatment for SD? And what causes SD? And then we used ChatGPT 4.0 Mini to rewrite the answers to those questions that were provided on the website using 6th grade language, using plain language principles at basically a 6th grade reading level. And ChatGPT was very good at doing that. I mean, it provided very good information in terms of the readability. But then the question became, how accurate is the information? And for the most part, the information was accurate, but it was not 100% accurate. So I would never, based on the way ChatGPT revised the materials, hand that information off to a patient without checking it first. It definitely needs to be vetted by expert review and content experts such as myself or others who have expertise in the area, because there's just there's too much room for there to be an error in the rewriting of the material. Even though it looks easier to read, and it is in fact easier to read, it doesn't necessarily translate 100% of the time to being as accurate as the original source material. And again, this is not unique. I mean, this is just one of many, many studies that we've done at our Explain lab at UCF. But it certainly adds to, the body of literature that shows now clearly that AI can be a tool, but like any other tool, it's a tool that needs to be used appropriately for the right purpose and has to be placed in the hands of the right person. So this is an area that I think, going forward, whether it be, through this cancer network or others, this is an area I think that's really ripe for research, because patients are coming in, patients are asking about AI. I had a friend who took some patient education materials that they had, and they asked ChatGPT to rewrite it for them so that they could read it. And then they showed me the material and I read it and I was like, that is not accurate. I know it's easier to read, but it's just not accurate. And I had to have a frank conversation with them about that, in a supportive way. So I think this is an area that's really ripe for more research. I think there should be more funding put into this area of research. And I think, again, it's a wonderful tool, but again, it's a tool that needs to be used with responsibility.
Well,
Thank you.
Richard, thank you very much. I must say that you're practicing what you preach. I hope you realize that your presentation style is hyper clear and hyper specific. You have great focus. Your material is easy to read and understand. Your verbal presentation is great. I mean, I think in a
Thank
way,
you.
you're kind of giving us a little health literacy 101 by demonstration. And
Well,
so,
thank you very much. I will say that
yeah,
I didn't start that way. So, I mean, maybe it's taken not quite 40 years, but I would say probably the first 10 years of my career, I wasn't as in tuned to it. And I'll tell you real briefly, just a
yeah.
30-second story. What got me into this area of research was one day I gave a patient-reported outcome measure to a voice client, and I walked out of the room. And I came back, and it should have taken them about 5 minutes to complete it. And almost by the time I hit the door, they were almost done. So I stepped outside the room. I peeked back in to see what they were doing. And they were going down the list of questions. And it looked like they were just randomly circling the questions, the answer choices. And their wife was sitting there. So I came back in and I said, wow, you did that rather quickly. Do you have any questions? And no. And I said, well, let's talk about some of these questions. And it turned out, after I talked to the patient briefly, that they essentially told me they couldn't understand most of the questions. And they just kind of thought, well, 3 was probably the typical answer that people give. And that's why they chose 3. And I remember my student was sitting there just kind of dumbstruck, And I was like, well, there's
Wow.
the old adage, junk in, junk out, right? We could have made a clinical decision or a recommendation based on this information. Had I not peeked into the room, I probably would never have known that, right?
Wow.
So, I think we all have those experiences, those of us that are clinicians, where we just frankly just missed something that we should have seen.
Well, thank you for that revelation about your own experience. And like I say, uh, this ought to be health literacy 101, Richard. I mean, you
Thank
nailed
you.
it. Thank you very
I,
much.
you're welcome. I do have the handout, has all of the sources that are on the slides, as well as some additional references for you as well.
Great. Thank you so much.
Thank you.
I'm delighted to hand it over to Dr. Alyssa Schatz for some closing insights and wisdom. Alyssa.
Thank you so much, Dr. Goodman. And thank you also to all of our incredible presenters and panelists today. You all shared insights that were not only rich, but also actionable. I know that personally I took away a lot of lessons that I'll be able to apply to my own practice and my own advocacy. And I also want to take a moment to thank our wonderful virtual audience for being here with us today. Your engagement, your questions, your comments, your generous sharing of your own personal experiences with this critically important topic and how it's impacted your own healthcare experience has been so powerful and again, really actionable insights. So thank you very much to our audience for that. I also want to thank our wonderful moderator, Cliff Goodman, and of course, the NCCN staff who made today's event possible, including our wonderful meetings team, our marketing team, and our policies team. And I also want to say a huge shout out and a special thank you to Erin Bailey, who did a wonderful job of leading today's event from the concept through the coordination to the execution of today's event. So well done, Erin. I also, of course, want to thank our wonderful sponsors for today's event. Today's event would not be possible and could not be a reality without their generous support. So we are thankful to all of them. And I'm just going to quickly read our supporters' names here. Thank you to AbbVie Inc., ADC Therapeutics America Inc., AstraZeneca Pharmaceuticals LP, B1 Medicines Inc., Boehringer Ingelheim Pharmaceuticals Inc., Bristol Myers Squibb, Eisai Inc., EMD Serono, Exelixis, Genentech USA, Gilead Sciences, GlaxoSmithKline, Insight Corporation, Johnson & Johnson Healthcare Systems, Lantheus Medical Imaging, Lilly Novartis Pharmaceuticals Corporation, Pfizer Regeneron Pharmaceuticals, Sanofi and Sun Pharmaceutical Industries Inc., and Merck & Co. Inc. as well. Thank you all to our generous supporters for supporting this event and also for your commitment to the importance of health literacy and cancer care. Before we conclude, I just want to share a couple of upcoming events that NCCN has, all of which are fantastic, and we hope you'll be able to join us for. The first is coming up in just 2 weeks from today on May 21st at 8 a.m. Eastern Time. This is a global policy webinar series, The Growing Cancer Burden in Young Adults. We know this is a huge issue globally around early onset cancer, so we hope you'll be able to join us for this important conversation. And registration is open now. The next event in this series takes place next month on Thursday, June 25th, 2026. The next theme will be Innovations in Cancer Care Through the Ages. It's going to be a dynamic and engaging event. Registration is open now, and we hope that you will be able to join us for that event as well. From September 18th to 19th, we will be at the New York Marriott Marquis in New York City for the NCCN 2026 Hematologic Malignancies Conference, and we hope you can join us. And of course, some very exciting news about the next NCCN annual conference taking place. We'll have our nursing program on Thursday, March 18th, 2027, and the annual conference Friday, March 19th to Sunday, March 21st, 2027. And the exciting news is that for the first time ever, this conference is taking place on the West Coast at the beautiful Hilton San Diego Bayfront in San Diego, California. So we hope you'll be able to join us there and maybe enjoy some of the beautiful warm weather as well. And with that, I just want to thank everyone again for attending, for participating, and we look forward to seeing you all at our upcoming events. Thank you very much and have a great day.